Welcome to the Deep Dive. Today, we are venturing into a part of human anatomy that is, well, absolutely fundamental, involved in core biological processes that are essential for life, yet often remains less discussed than other organ systems. We are talking about the male and female urethra and the penis. These are structures vital for essential functions, and as our source material reveals, they're susceptible to a surprisingly wide and complex range of conditions. From issues present at birth to those acquired through trauma, infection, or even malignancy.
And what's particularly striking, I think, is the clinical significance of these conditions. They aren't always minor things. They can involve significant pain, complex diagnostic workups, challenging surgical interventions, and in some cases, they actually represent true medical emergencies requiring immediate action.
Right.
Understanding these structures and their potential issues isn't just academic. It's really about appreciating key aspects of human health and disease from a clinical perspective.
Absolutely. And our mission in this deep dive, based on the material you've shared, is to go deep. We're aiming for a level of understanding that feels like you're truly grappling with this information, like professionals in the field would. We're using excerpts from a respected surgical practice guy, Bailey and Love, as our sole source. This means we'll be focusing on the anatomy, the clinical presentation of various conditions, the diagnostic approaches outlined, and the principles of management and treatment discussed in this text.
Think of this as a guided exploration through a pretty dense informative text. We're going to unpack it section by section, revealing the key insights and essential knowledge points about the anatomy, congenital abnormalities, traumatic injuries, strictures, other conditions, infections, and neoplasms affecting these structures. Everything we discuss, every detail, every diagnostic method, every treatment principle, it's all drawn directly from this specific source, Bailey and Love.
Exactly. Our goal is to provide you with a structured, detailed understanding, helping you connect the dots and build a robust picture of these structures and their potential pathologies. We'll make sure it feels like a conversation and engaging exploration rather than, a dry reading.
Right.
So let's begin this deep dive. Let's start at the beginning with the fundamental anatomy of the male urethra.
Okay, let's unpack this crucial pathway. Fundamentally, the male urethra is a fibromuscular tube. It starts internally, connecting to the bladder neck, and extends all the way to the meatus, which is the external opening located at the very tip of the glans penis.
And this tube serves not one, but two critical purposes.
Precisely. Yeah, it's a dual-function conduit. Its primary role, which, most people think of, is transporting urine from the bladder out of the body. But equally important, it's the pathway for transporting semen from the ejaculatory ducts through the penis during ejaculation. So it's integral to both the urinary and reproductive systems.
Got it. And the source breaks down this tube into distinct segments. Could you guide us through these subdivisions, maybe moving from the outside world inwards towards the bladder?
Certainly. Starting at the distal end, the very external opening is the meatus. The source describes it as having a vertical slit-like shape located right at the tip of the glans.
Okay.
Just inside the meatus, within the glans, is the glandular part of the urethra, known as the fossa navicularis.
Okay, meatus, then the fossa navicularis just inside. What comes next along the path?
Moving proximally, so going further in from the fossa navicularis back to a point called the penoscrotal junction, that's where the penis meets the scrotum, is the penile urethra. This segment is surrounded by a specific type of erectile tissue called the corpus spongiosum.
The corpus spongiosum, right? Distinct from the larger corpora cavernosa that run along the top of the penis. It's the tissue that protects and supports the urethra during erection.
That's correct, yeah. It encircles the urethra in this section. Continuing inwards from the penoscrotal junction to the bulbar membranous junction is the bulbar urethra. And like the penile urethra, this section is also surrounded by the corpus spongiosum.
So the penile and bulbar segments, together often called the anterior urethra, are both enclosed within the corpus spongiosum. Where does the pathway go from the bulbar membranous junction?
This leads us to a very important anatomical segment, the membranous urethra. It extends from the bulbar membranous junction back to the verumontanum, which is a small elevation found within the prostatic urethra.
Right.
Now, what makes the membranous urethra crucial is that it's surrounded by the voluntary external sphincter.
The voluntary external sphincter, that's the muscle under conscious control for starting and stopping urination, right?
Exactly. And the source specifies that this sphincter is actually quite a complex structure, consisting of both smooth muscle components and the striated rhabdosphincter, which is skeletal muscle. This voluntary control is facilitated by its innervation, receiving nerve supply from the pudendal nerve, originating from spinal segments S2 to S4.
Wow, that level of detail really highlights the precise neuromuscular control required for continence. And the final segment before the bladder.
The innermost section is the prostatic urethra. It runs from the bladder neck, the very base of the bladder, all the way to the verumontanum. And as the name suggests, this segment passes through and is surrounded by the prostate gland.
So to recap the segments from outside in, menatus, fossa navicularis, penile urethra, bulbar urethra, membranous urethra, and prostatic urethra. Understanding these specific regions seems essential for localizing conditions.
It absolutely is. Yeah, the location of an injury, or a stricture, for example, is often described by which of these segments it affects. It's really key terminology.
Now let's talk more about that control mechanism. How do the bladder neck and these sphincters work together for continence and ejaculation?
Well, the bladder neck, located right at the start of the prostatic urethra, it definitely contributes to maintaining continence in men. However, the source clarifies that its main role functions as a genital sphincter.
A genital sphincter.
Yeah, its primary purpose is to close tightly at the moment of ejaculation. This prevents what's called retrograde ejaculation, where semen flows backward into the bladder instead of forward through the urethra.
Ah, so the bladder neck is more about preventing semen from going the wrong way, while the external sphincter is more for controlling urine flow out of the bladder. Makes sense.
Precisely. And the source notes a key point regarding continence. Both the bladder neck and the external sphincter can independently maintain continence in men.
Independent.
Yes. This provides a degree of functional redundancy. If one mechanism is impaired, the other might still be able to prevent leakage. It's quite a clever design.
That's an important piece of functional anatomy. And what about the lining of this tube? Does the tissue change along its length?
Yes, it does. The type of epithelial lining changes as you move from the bladder outwards. Proximally near the bladder, it's lined with transitional cell epithelium, the same type of flexible multi-layered tissue that lines the bladder itself.
Right.
As you move distally towards the meus, this gradually changes to stratified squamous cell epithelium, which is more similar to skin.
So different tissues lining the urethra depending on where it is in its environment. Okay, that foundational anatomy sets the stage. Now, let's transition to conditions that can arise from problems during development. Issues present right from birth, congenital anomalies of the male urethra.
A critical area, definitely, as these can have profound impacts very early in life. Let's start with posterior urethral valves.
Posterior urethral valves. This sounds like a physical blockage. How common are they?
Well, the source states the incidence is around 1 in 8,000 live male births. So while not the most common congenital issue we'll discuss, it's significant enough to be well recognized by pediatricians and urologists.
And what exactly are these valves? Where are they located?
They are described as thin membranes within the urethra, typically located just distal to the verumontanum, that structure we mentioned in the prostatic urethra. These membranes have a small posterior slit.
How do they cause obstruction? Are they always closed?
They function like flap valves. They are obstructive to antegrade urinary flow, meaning they block urine trying to flow forward out of the bladder. But here's a key diagnostic clue from the source. A urethral catheter can often be passed retrogradely back into the bladder without difficulty.
Oh, interesting.
Yeah, the catheter essentially pushes the flap open as it's inserted.
That's a clever way to understand how they work and are identified. And why is early detection and treatment so crucial for posterior urethral valves?
Well, because the obstruction causes pressure to build up behind the valves, backing up into the bladder, the ureters, and the kidneys. This high pressure and stagnant urine can severely damage the developing kidneys. The critical need is for early detection and treatment to minimize the degree of irreversible renal failure. It's really time sensitive.
That highlights the urgency. How are these diagnosed, especially early on? Can they be picked up before birth?
Yes, diagnosis can actually begin antenatally with ultrasound. Typical findings described in the source include a distended bladder, a dilated prostatic urethra, the part just behind the obstruction, and hydroretronephrosis.
Hydroretronephrosis.
Yeah, it's swelling and dilation of the ureters and the collecting systems within the kidneys caused by the urine backup.
So, clues even before birth. What about after a baby is born? How might they present?
Postnatally, the presentation varies with the severity of the obstruction. More severe cases present earlier, often with parents bringing the baby in due to avoiding complaints or recurrent urinary tract infections, UTIs. In rare cases with less obstructive, sort of incomplete valves, presentation might be delayed until adolescence or even adulthood.
How do they assess the impact on the kidneys after birth?
Impaired renal function is assessed using several methods. Ultrasound is used to evaluate the thickness of the renal cortex, the outer filtering part of the kidney, and nuclearonography is performed to determine the differential renal function, basically, how well each kidney is functioning individually.
And what's the definitive imaging test to confirm the diagnosis?
The key investigation is a voiding cystorethogram, or VCUG. The source describes the classic findings: a markedly dilated posterior or prostatic urethra above the level of the obstruction. The bladder is often hypertrophied, thickened from pushing against the resistance, and may show diverticula, small pouches bulging out. Vesicurital reflux, where urine flows backward from the bladder into the ureters, is also typically present.
So that VCUG finding sounds very distinctive.
It really is. Figure 85.1 in the source clearly illustrates this characteristic dilated prostatic urethra on a VCUG. It's quite striking.
How are these valves treated?
The initial management usually involves catheterization to drain the bladder and decompress the entire system, relieving the pressure on the kidneys, get the urine flowing.
To get the urine draining first, then what's the definitive fix?
The definitive treatment is endoscopic ablation of the valves. This means using instruments passed through a scope inserted into the urethra to cut or remove the obstructing valve membranes.
The source mentions that seeing the valves clearly during the scope can be tricky, though. Why is that?
Yes, it notes that the valves can be difficult to see distinctly on urethroscopy because the flow of the irrigating fluid used during the procedure can sweep the delicate valve membranes into the open position, kind of obscuring the view.
Like trying to see a flag in the wind. So, diagnosis often relies heavily on the VCUG findings before the endoscopic treatment. And is that the end of the journey once the valves are ablated?
Unfortunately, not always. Due to the potential for associated vesicurital reflux, the development of bladder dysfunction from working against the obstruction for a prolonged period, and the possibility of existing renal impairment, long-term follow-up is required for these patients. They need monitoring to manage these ongoing issues like recurrent UTIs, bladder problems, and kidney function.
Okay. Summary box 85.1 reinforces those key points. Congenital membranes, diagnosis via antenatal ultrasound or VCUG, treatment by endoscopic ablation, and that crucial need for long-term follow-up. That's a detailed look at posterior urethral valves. Now, let's discuss what the source identifies as the most common congenital abnormality of the urethra: hypospadias.
Hypospadias is indeed much more prevalent than posterior urethral valves, occurring in approximately 1 in 300 male live births.
1 in 300 is a significant incidence. How is hypospadias diagnosed? Is it obvious?
Diagnosis is made quite simply on physical examination, usually right after birth. The source outlines a characteristic trio of features used for identification.
The 3 key signs, what are they?
First, an ectopic, ventrally located urethral meatus. Ectopic means it's not in its normal position at the tip of the glands. Ventrally means it's located somewhere on the underside of the penis shaft, or even further back.
Okay, opening in the wrong place on the bottom.
Second, there is usually ventral penile curvature, known as chordee, where the penis curves downward, especially noticeable during erection later in life. And third, there's an incomplete dorsal hood prepuce. The foreskin is deficient on the top side, often giving a hooded appearance dorsally and being split ventrally.
Right. Figure 85.2AD visually depict the varying locations of the meatus in different classifications.
Yes, the classification helps describe the severity and guides treatment. Types include glandular, where the meatus is on the glands but proximal to the tip, coronal, at the groove behind the glands, penile, located along the shaft, and penoscrotal, at the junction of the penis and scrotum.
And there's a very severe form mentioned.
Yes, perineal hypospadias. This is rare and represents the most severe end of the spectrum. In these cases, the scrotum is bifid, split into 2 halves, and the urethra opens between these halves in the perineum.
That's a significant developmental difference. Are there other conditions that severe hypospadias might be associated with?
This is an important clinical consideration from the source. In children presenting with severe hypospadias, particularly when associated with other abnormalities like undescended tests, hernia, and micropenis, it's crucial to investigate for possible disorders of sexual development, or DSD.
So, severe hypospadias can be a red flag for other underlying hormonal or genetic conditions. What about treatment? Is surgery always necessary?
Well, the source notes that surgery for distal hypospadias, where the meatus is closer to the tip, is often performed primarily for cosmetic reasons, although it can also improve function, like directing the urinary stream. However, more proximal hypospadias, or any degree of hypospadias with significant chordee, requires surgical correction to allow for normal voiding and future sexual function. Makes sense? What are the surgical approaches?
For distal hypospadias, the common approach is a tubularized incised plate urethroplasty, often referred to as the Tipley or Snodgrass procedure. This involves incising the urethral plate on the underside and tooting it to create a new urethra. For more proximal hypospadias with significant chordee, a two-stage repair might be necessary.
2 stages.
Yeah, the first stage focuses on correcting the penile curvature chordee, often releasing the tight tissue causing the bend. Then a later second stage repairs the urethra using various techniques, sometimes involving grafts.
The staged approach for the more complex cases. And there's a crucial point about something that should absolutely not be done in infants with hypospadias. Yes, this is a vital piece of advice in the source. Circumcision should be avoided in infants with hypospadias.
Why is that?
The reason is that the preputial skin, the foreskin, often provides valuable tissue that may be needed for future reconstruction of the urethra during the hypospadias repair or any necessary revisions. Removing it eliminates this potential graft material. It's really important for parents and non-specialist doctors to know this.
That's a really practical and important point. And who should perform the surgery and when?
Surgery for hypospadias is complex and best performed by experts specifically trained in hypospadia surgery, pediatric urologists usually. It's typically undertaken before the age of 18 months.
Specialists performing the repair relatively early in life. What happens if a hypospadias repair isn't successful? Are there common complications?
A potential complication of a failed hypospadias repair is the formation of a urethral-cutaneous fistula, which is an abnormal tract or hole from the newly created urethra to the skin surface of the penis, causing urine leakage. Figure 85.2e shows an example.
Okay. Summary box 85.2 provides key points. Diagnosis is clinical by meatus position, hooded foreskin, and chordee. Severe cases may be associated with DSD. Crucially, avoid circumcision. Surgery by experts before 18 months, and failed repair can cause that fistula.
That sums it up well.
A comprehensive look at hypospadias. Let's briefly touch on epispadias. This sounds similar but different.
Epispadias is considerably rarer than hypospadias. In penile epispadias, the urethral opening is located on the dorsum, the top side of the penis, not the tip or bottom. This is associated with an upward curvature of the erect penis, the opposite direction to the chordee seen in hypospadias. Figure 85.3 illustrates this dorsal opening.
So top opening and upward bend versus bottom opening and often downward bend in hypospadias. Got it.
Exactly. And epispadias often coexist with more severe congenital anomalies, particularly bladder exstrophy, a condition where the bladder is open to the outside from birth, and other complex developmental defects. It's usually part of a larger picture.
That sounds like a more serious and complex constellation of issues. Finally, regarding congenital problems, urethral diverticula.
Right. Congenital urethral diverticula are rare from birth. However, the source notes that urethral diverticula are actually commonly seen as an acquired problem, often post-urethroplasty, particularly when genital skin is used for augmentation, as shown in figure 85.4.
Ah, interesting. So it's listed as a congenital possibility, but more often a complication of treatment or other issues.
Exactly. So while it can be congenital, it's frequently iatrogenic or acquired after surgery.
How does a urethral diverticulum typically present? What are the symptoms?
Patients typically complain of post-micturition dribble. Basically, urine collects in the pouch or diverticulum after voiding and then leaks out later, which can be quite bothersome.
And diagnosis and treatment for a diverticulum?
Diagnosis is made by urethroplasty, the X-ray with contrast. The treatment involves surgical repair of the diverticulum, usually excising the pouch.
Okay. That concludes our look at issues that can arise during development. We've covered posterior urethral valves, hypospadias, the rare epispadias, and urethral diverticulum, drawing directly from the source material. Now, let's move into problems that occur later in life due to external forces, traumatic injuries to the urethra.
A very different category of conditions, yes, involving acute physical damage. Let's start with bulbar urethral trauma.
The bulbar urethra, located in the perineum, just below the scrotum, encased in the corpus spongiosum. How does this part of the urethra typically get injured?
The usual mechanism described is a falling astride injury. This is blunt trauma to the perineum caused by landing forcefully on a narrow, hard object. Common examples from the source include falling from a tree, cycling accidents where you land on the crossbar, skating accidents, or various industrial incidents.
Ouch.
Yeah, the bulbar urethra is crushed upwards onto the inferior edge of the pubic bone. This type of injury typically involves significant bruising in the area.
So compression against the bone. What are the key clinical features that would make you suspect a ruptured bulbar urethra?
The classic signs listed are perineal bruising and hematoma, which often presents with a characteristic butterfly distribution across the perineum and extending up onto the scrotum. There's usually bleeding from the urethral meatus. That's a critical sign of any urethral injury. And due to the damage, the patient experiences retention of urine they cannot void.
Butterfly bruising, meatal bleeding, and inability to urinate clear indicators of a problem. How is bulbar urethral trauma managed? What's the first step?
The essential investigation for diagnosis is a retrograde urethrogram, RGU. This involves injecting contrast dye gently into the urethra from the meatus to see if it flows into the bladder or leaks out at the site of injury. The source mentions that a gentle attempt at catheterization may be made initially.
But if that catheter cannot be passed, or if the RGU confirms a significant injury, what then?
Crucially, if a catheter fails to drain urine, a suprapubic cystostomy is performed. This means placing a drainage tube directly into the bladder through the lower abdominal wall above the pubic bone. This diverts urine away from the injured urethra, preventing leakage and allowing the injury to stabilize. Figure 85.5 illustrates the technique for a percutaneous suprapubic cystostomy.
So bypass the injured area to manage urine flow. What's considered the definitive treatment for these bulbar injuries once the patient is stable?
The definitive treatment is delayed anastomotic urethroplasty. This surgical repair of the urethra is performed after a delay, typically 3 months following the injury. This allows swelling and inflammation to subside and the full extent of the scar tissue to declare itself. The source notes excellent success rates with this delayed approach.
Okay, so delay repair has good outcomes. Summary box 85.3 confirms the key points. Cause is blunt perineal trauma. RGU is diagnostic. Suprapubic cystostomy if catheterization fails. And delayed urethroplasty is the treatment of choice with excellent results.
That's it.
Okay, that covers bulbar trauma, often an isolated stratal injury. Now let's look at urethral injuries that are often associated with more severe trauma, pelvic fractures.
These are often part of major traumatic events and have a significant association with urethral damage. The incidence of posterior urethral injury and pelvic fractures is approximately 10%. These are typically crush injuries, most commonly resulting from high-energy impacts like road traffic accidents.
So much greater force involved. Where's the urethra typically injured in a pelvic fracture?
The site of injury is usually the bulbomembranous junction, that transition point between the bulbar and membranous urethra where it passes through the pelvic floor muscles.
And what happens there?
The source describes the mechanism as a disruption. The bladder, along with the prostate and the membranous urethra, is essentially detached or sheared away from the bulbar urethra. The displacement can be considerable, both posterior and superior. Figure 85.6 illustrates this disruption and upward displacement seen on an RGU quite clearly.
So the whole upper segment is pulled away from the lower. Can these be partial or complete injuries?
Yes, the injury can be a partial tear or a complete disruption. Occasionally, these injuries are very complex, also involving disruption of the bladder, neck, or even a rectourethral fistula, an abnormal connection between the urethra and the rectum.
Those complex cases sound incredibly challenging. What are the clinical features and what's the immediate medical priority?
As these are often part of major trauma scenarios, the absolute initial priority is resuscitation and hemodynamic stabilization of the patient, the ABCs of trauma care, managing life-threatening injuries first. Clinical features specifically related to the urethral injury mirror some of those in bulbar trauma: blood at the meatus and urinary retention.
So the signs are similar, but the patient's overall condition is likely much more severe. How is the urethral injury diagnosed in this setting?
The urethral injury is often first suspected or even diagnosed during the initial imaging performed as part of the general trauma assessment, such as an ultrasound, fast scan, or CT scan. To specifically confirm and delineate the urethral damage, a retrograde urethrogram, RGU, is performed, just like for bulbar injuries, as shown in figure 85.6.
The RGU remains the key test for visualizing the injury. How are these injuries initially managed? Is it the same suprapubic catheter approach?
Pretty much, yes. If the RGU suggests a partial tear, a gentle attempt at catheterization may be made. However, if urine doesn't drain or if it's a complete disruption, a suprapubic cystostomy is the essential initial step. This can be done percutaneously or via an open surgical approach. It ensures the bladder is drained and urine is diverted. For complex patients, more detailed imaging like 3D CT or MRI of the pelvis might be needed to fully understand the extent of associated injuries.
And if there are associated injuries like bladder rupture or rectal tears?
Emergency laparotomy is required for repair of bladder ruptures or significant bladder and neck injuries. If there's an associated rectal injury, a diverting colostomy is performed to divert feces and protect the injured area from contamination during healing.
So initial management is all about stabilization, diagnosis, and safe urinary and potentially bowel diversion. What are the longer-term treatment options for repairing the urethra itself? Is it always delayed?
Mostly delayed repair is the standard. However, the source mentions that in some centers, an early endoscopic realignment is attempted once the patient is stable. This involves navigating scopes and guide wires through the injured segment to try and bridge the gap, then placing a catheter to stent the area and allow healing.
That sounds technically demanding and potentially risky.
It absolutely is. The source notes it's challenging and not always successful, with an increased risk of infection to the surrounding hematoma. However, if successful, it might potentially avoid the need for later open surgery. Even if it fails, it may shorten the gap between the urethral ends, possibly making subsequent surgery easier.
So a possible but not guaranteed shortcut. What's considered the gold standard for definitive repair?
Delayed anastomotic urethroplasty. As with bulbar trauma, this surgical reconstruction is the treatment of choice, performed after a delay of 3 to 6 months. The source strongly emphasizes that this is a highly challenging procedure requiring specialized expertise and should be undertaken at centers with significant experience, as this leads to higher success rates. It's not routine surgery.
Delayed repair by experts for these severe injuries. What are the potential long-term complications after pelvic fracture urethral injury?
A common complication is erectile dysfunction, ED. The causes can be vasculogenic due to damage to blood vessels like the dorsal penile arteries, or neurogenic damage to the cavernosal nerves which run close to the injured area.
How is ED evaluated in these patients according to the source?
Erectile function is evaluated using penile Doppler ultrasound. This is often performed after an intracavernosal injection of a vasoactive agent like papaverine, which helps induce an erection. The Doppler ultrasound then assesses the velocity and characteristics of blood flow in the penile arteries to evaluate the vascular supply.
And what's the prognosis and treatment for this post-trauma ED?
The source notes that patients often experience some recovery of erectile function over time, sometimes for up to a year after the injury. For those who don't recover, treatment follows a stepwise approach, starting with oral agents like sildenafil, a PDE5 inhibitor. If that fails, options include self-intracavernosal injections, vacuum devices, or ultimately a penile implant, which the source notes is becoming increasingly popular.
So ED is a significant complication, but treatable. What about urinary control? Is incontinence common?
Urinary incontinence is rare after these injuries, thankfully. However, the risk is higher in those complex cases where the injury involves the prostate membranous urethra and includes a bladder neck tear, as the bladder neck is a primary continence mechanism in men. Damaging both sphincters is bad news for continence.
Makes sense. And finally, since these are associated with pelvic fractures, there are also orthopedic considerations.
Yes. The fractured pelvis itself requires stabilization, which is performed by orthopedic surgical teams using external or internal fixation methods. Summary box 85.4 reinforces key points. Suspect urethral injury with blood retention in pelvic fracture. RGU is diagnostic. Initial management is suprapubic drainage, and delayed anastomotic urethroplasty by specialists is the high success definitive treatment, with ED being a common complication.
We've covered congenital issues and acute trauma. Now let's turn our attention to a common chronic problem resulting from scarring and narrowing: urethral stricture.
Urethral stricture is a significant issue causing voiding difficulties. The source defines it as an abnormal narrowing of the lumen of the urethra caused by fibrosis or scar tissue. And it's worth noting the management of strictures has seen considerable evolution over the past 25 years, moving towards more definitive reconstructive surgery or urethroplasty.
And the source lists quite a few causes or etiologies for strictures. It's not just one thing.
No, definitely not. The common causes are detailed. They include lichen sclerosis, LS, which causes dense scarring; iatrogenic causes, meaning strictures caused by medical intervention like catheterization or endoscopic procedures; sexually transmitted diseases, historically gonorrhea being a major cause, though less common now with effective antibiotics; post-radiation therapy; traumatic injuries from those previous injuries we discussed; idiopathic causes where the reason is just unknown; and rarely congenital strictures.
So a broad spectrum of origins leading to the same problem of narrowing. How do these causes lead to the scar tissue and narrowing? What's the pathophysiology outlined?
Let's look at some key mechanisms. Post-inflammatory strictures, like those historically linked to gonorrhea, developed when infection in the small periurethral glands persisted after inadequately treated gonorrhea. This led to inflammation spreading to the periurethral tissues, a sort of periurethritis, and this inflammation then healed by fibrosis, or scarring, constricting the urethral lumen. These strictures were often found in the bulbar urethra and could manifest symptoms within a year or sometimes much later.
So chronic or poorly treated inflammation causes scarring. What about lichen sclerosus, or LS? That sounds quite specific.
It is. LS, previously known as balanitis erotica obliterans, BXO, is a specific chronic inflammatory condition that causes progressive fibrosis. It's characterized by scarring of the foreskin, leading to phimosis, and can involve the glands with whitish patches. Within the urethra, it causes meatal stenosis, narrowing at the tip, and often long, dense strictures in the penile urethra.
What causes LS?
Its cause is debated, still somewhat unknown, but studies suggest it might be an autoimmune condition or perhaps triggered by infection. It can be diagnosed visually and confirmed by biopsy and exists in active inflammatory and burnt-out fibrotic forms. The strictures from LS are notoriously long and challenging to treat, commonly affecting the penile segment or even the entire urethra, periurethral strictures, although isolated bulbar LS strictures are also seen.
LS sounds like a particularly aggressive cause of scarring. What about strictures caused by medical procedures, post-instrumentation?
These strictures can occur after endoscopy or catheterization and may affect any part of the urethra, depending on where the trauma occurred. The source also specifically highlights post-terpesic strictures, occurring after transurethral resection of the prostate. These tend to occur in specific areas. The submeatal area, just inside the tip, the bulbar urethra, or the penoscrotal junction. Relatedly, bladder neck stenosis, a narrowing at the bladder outlet itself, can follow TURB or radical prostatectomy.
Okay, various pathways leading to this narrowing. How do patients with urethral stricture typically present clinically? What symptoms do they notice?
The clinical features usually involve difficulty with urination due to the obstruction. Patients commonly report hesitancy, difficulty starting the stream, a poor or weak flow, and a prolonged voiding time, standing there for ages. Recurrent UTIs are frequent because of incomplete bladder emptying and urinary stasis. Occasionally, the stricture may lead to acute urinary retention, the sudden inability to urinate at all.
What investigations are used to diagnose and assess urethral strictures?
Several methods are employed. Uroflowmetry is often an initial test, measuring the flow rate. The source notes the typical finding is a prolonged voiding time with a characteristically low, sustained flow rate that results in a box pattern on the flow trace, as shown in figure 85.7, rather than the normal bell-shaped curve.
That box pattern indicates a constant low flow against resistance. Very visual.
Exactly. Urethrography is essential. Both retrograde urethrogram, RGU, and voiding Custer urethrogram, VCUG, are performed using water-soluble contrast medium. These X-rays clearly visualize the location, length, and severity of the stricture, figures 85.8 and 85.9. Urethropy provides direct visualization, often used intraoperatively during surgery to assess the stricture texture and length, figure 85.10. Ultrasound scanning can be used to assess bladder emptying, post-void residual urine, and check for any upper tract dilatation resulting from chronic obstruction.
And if strictures are left untreated, what are the potential complications?
Untreated strictures can lead to significant complications, including recurrent UTI, persistent or acute urinary retention, upper tract dilatation potentially damaging the kidneys over time, bladder stones forming in the stagnant urine, and periurethral abscesses, which we discussed earlier.
So treatment is important to prevent these downstream issues. You mentioned management has evolved. What are the treatment approaches described? Has dilatation fallen out of favor?
Historically, urethral dilatation was a mainstay, practiced for thousands of years, believe it or not. In the past, this involved serial passage of metal dilators, often under local anesthesia, with risks of pain, fever, bleeding, and creating false passages. Modern practice uses serial plastic dilators, often passed over a guide wire, which is safer. Dilatation is most effective for soft, short strictures and is an option for patients unfit for surgery, those who decline more complex procedures, or those with multiple failed previous repairs.
But dilation is usually not a permanent fix, right?
Correct. The source explicitly states that urethral dilation rarely cures the stricture, and most patients require repeated dilations over time to maintain patency. It's more management than cure.
What about direct visual internal urethrotomy, or DVIU, cutting the stricture?
DVIU involves incising the stricture using an optical uretratome, a scope with a cutting instrument under direct vision, typically using a cold knife or laser fiber, like holmium or thulium. It's indicated for short, non-traumatic strictures, particularly in the bulbar urethra. However, the source provides a critical warning. DVIU should not be used in the penile urethra or the sphincter-active membranous urethra.
Why not in those areas?
In the penile segment, the surrounding corpus spongiosum is very vascular, and cutting into it carries a significant risk of bleeding and further scarring. In the membranous urethra, there's a high risk of damaging the external sphincter, which could cause permanent urinary incontinence. So location is key for DVIU.
So DVIU is useful, but only in specific locations. What's an option for patients who prefer self-management or aren't surgical candidates?
Self-dilatation or clean intermittent catheterization, CIC. This involves the patient regularly inserting a small catheter into their own urethra. It doesn't cure the stricture, but helps keep the channel open. It's an option for motivated patients unwilling or unable to undergo surgical reconstruction.
And the primary surgical approach for definitive repair, urethroplasty.
That is urethroplasty, surgical reconstruction of the urethra. The source distinguishes two main types. Anastomotic urethroplasty is the preferred technique for traumatic bulbar urethral strictures where there is a gap, or for short non-traumatic bulbar strictures. It involves surgically excising the scarred segment, dissecting the two healthy ends, spatulating them, making small cuts on the sides to widen the opening, and then sewing them back together, anastomosis. The source notes a high success rate of around 90% over 10 years for this method.
Cutting out the diseased segment and rejoining the healthy ends. What's the other main type of urethroplasty for longer strictures?
Augmentation urethroplasty. This is used for non-traumatic and long strictures. Instead of cutting out the segment, the strictured urethra is incised lengthwise, and a patch or graft of tissue is used to widen the narrowed area, essentially augmenting the urethral lumen.
What tissue is typically used for the graft? Where does it come from?
The most common choice is buccal mucosa, tissue harvested from the inside of the cheek. It's proven to be a very reliable graft material. The source also mentions lingual grafts from the undersurface of the tongue as an alternative material.
Buccal mucosa is widely used. And are there different techniques for augmenting? How is the graft placed?
Yes, based on how the graft is placed relative to the incised urethra. Techniques include dorsal onlay augmentation, where the graft is sewn onto the top surface of the incised urethra, dorsal inlay, where the urethra is open dorsally and the graft placed within, or ventral onlay, where the graft is placed on the underside. The choice often depends on the location and surgeon preference. The success rate for augmentation urethroplasty is also high, around 85% over 10 years.
High long-term success rates for these surgical repairs. What about very long strictures, like those panurethral strictures seen with LS? That sounds challenging.
Panurethral strictures affect a significant length of the urethra, often due to LS or previous iatrogenic causes. Figure 85.9 shows a long stricture. The treatment is still urethroplasty, but the surgical approach is more extensive. It involves a perineal incision, invaginating the penis, pulling it downwards and inwards into the wound to get access to the entire length of the interior urethra, dissecting the urethra, and performing a long dorsal onlay buccal mucosa urethroplasty, often requiring large grafts.
That highlights the complexity of these extensive strictures. The source also mentions using flaps sometimes instead of grafts.
Yes, perputial and penile fasciocutaneous flaps can be used. These are sections of skin and subcutaneous tissue with their own blood supply, vascular pedicle, which makes them more resilient than free grafts, especially in poorly vascularized areas. They can be particularly useful for complex posterior urethroplasty, bridging very long gaps, or for strictures resulting from radiation therapy where local tissue quality is poor.
So the choice of urethroplasty technique is tailored to the length, location, cause, and complexity of the stricture. And after urethroplasty, is that usually the end of it?
The source emphasizes that long-term follow-up is required after urethroplasty to monitor for potential recurrence or other long-term issues. While success rates are high, strictures can sometimes recur years later. Summary box 85.5 outlines the treatment strategies. DVIU for short bulbar, anastomotic for traumatic, augmentation for long non-traumatic strictures, and mentions the high success rates of urethroplasty.
That's a deep dive into urethral strictures. Let's briefly cover a few other conditions of the male urethra mentioned in the source before moving to the female anatomy.
Okay, first, urethral fistula.
We touched on this as a complication of failed hypospadias repair. Are there other causes?
Right, that's one common cause. The source also describes how severe, tight strictures, particularly when complicated by periurethral abscesses, can lead to multiple urethral fistulae, resulting in a condition graphically referred to as watering can perineum. Urine leaks out through multiple small holes.
Multiple openings, discharging pus or urine. a serious complication of severe stricture. What about stones forming in or getting stuck in the urethral calculi?
Urethral stones can occasionally originate within the urethra, perhaps forming behind a tight stricture or in an infected urethral diverticulum. However, more commonly, they are renal calculi kidney stones that have migrated down the ureter and bladder and become lodged in the urethra on their way out.
So often they started higher up in the urinary tract. How do urethral calculi present clinically?
They typically present with episodes of urinary retention, severe pain, or hematuria, blood in the urine, often sudden onset.
And how are they treated? Does it depend where they get stuck?
Yes, treatment varies by location. A stone lodged within the prostatic urethra is usually displaced back into the bladder, where it can be fragmented using laser or pneumatic lithotripsy. Calculi in more distal parts of the urethra can often be fragmented in situ using a laser, such as a holmium or thulium laser passed endoscopically. Large or multiple calculi located inside a urethral diverticulum may require open surgical removal.
Treatment guided by location. Finally, neoplasms, or tumors, of the urethra. Are these common?
These are rare, but any unexplained bloody urethral discharge without signs of infection should raise suspicion of a urethral tumor. The source notes that transitional cell cancer of the bladder can sometimes be multifocal, with associated tumors occurring in the prostatic urethra and occasionally more distally. These can sometimes be treated with local laser ablation, but they have a tendency to distance spread.
So bladder cancer can sometimes involve the urethra. What about squamous carcinoma of the urethra?
Squamous carcinoma is another type of urethral cancer, which may develop in an area of squamous metaplasia, a change in the tissue lining, sometimes seen in patients with lichen sclerosus. This type of cancer is typically treated by radical surgery and unfortunately carries a poor prognosis.
That covers the main conditions of the male urethra outlined in the source. Now, let's shift our focus to the female urethra. How does it differ anatomically?
Right. The female urethra has distinct anatomical features compared to the male. The source describes it as being significantly shorter than the male, typically around 4 centimeters long, extending from the bladder neck to the meatus.
And functionally?
A key functional difference highlighted is that the entire length of the female urethra is described as sphincter active, meaning its whole length contributes to continence, in contrast to the more localized sphincteric mechanisms in the male. It also receives structural support from the surrounding pelvic floor musculature.
Much shorter, and the sphincter function distributed along its full length. The source lists specific abnormalities affecting the female urethra. What are they?
Yes, the main ones covered are urethral caruncle, stricture, diverticulum, papillomas, genital warts, and carcinoma.
Let's start with a urethral caruncle. What is that?
The urethral caruncle is typically observed in elderly women. It presents as a soft, benign, raspberry-like mass about the size of a pea, located at the urethral meatus, usually at the 6 o'clock position, as shown in figure 85.11.
What is it anatomically? Is it a growth?
It is essentially prolapsed urethral mucosa, tissue from the inner lining that is kind of everted or come outside. Not really a tumor.
What symptoms does it cause?
Occasionally it can cause bleeding or local irritation.
And how is it treated?
It's symptomatic and requiring treatment. It is excised, and the base of the stalk is cauterized using diathermy coagulation. Often no treatment is needed if it's asymptomatic.
Okay, caruncle is a prolapse of mucosa. What about stricture in the female urethra? Is that common?
Urethral stricture is uncommon in women compared to men. Causes can include urethritis, trauma associated with prolonged or difficult labor, or instrumentation, similar to iatrogenic causes in men.
And the main consequence of a female urethral stricture?
An occasional consequence is urinary retention, which in these cases is usually chronic, causing difficulty emptying the bladder.
How is it managed?
Initially, like in men, management involves urethral dilatation. For recurrent strictures, the source advocates for surgical reconstruction, urethroplasty, typically using buccal mucosa augmentation, similar to the techniques used in men.
So, while rare, the management principles for stricture are similar. What about a female urethral diverticulum?
A female urethral diverticulum can be congenital, but is more commonly acquired. It can result from the rupture of a distended and infected periurethral gland, or from injury to the urethra during childbirth. It's an outpouching from the urethra.
How does a female urethral diverticulum cause symptoms?
Urine can enter and collect within the diverticulum, where it often becomes infected. This leads to local pain and repeated episodes of cystitis. A key diagnostic sign mentioned is the discharge of purulent urine when the urethra is compressed with a finger placed in the vagina, pressing on the diverticulum expels its contents.
That distinctive sign sounds very helpful clinically. How is it diagnosed with imaging?
Diagnosis is typically confirmed by MRI or transvaginal ultrasound. Figure 85.22 shows imaging of a female urethral diverticulum.
And treatment for a diverticulum?
Treatment involves surgical excision of the diverticulum through the anterior vaginal wall. The source adds a crucial caution here. Great care must be taken during excision not to damage the urethral sphincter, given its importance for continence along the full length of the female urethra. You really don't want to cause incontinence.
Protecting that sphincter is paramount. The source also lists papillomas condyloma acuminata under female urethral abnormalities.
Yes, also known as anogenital warts. They are caused by HPV infection, types 6 and 11 primarily, and are sexually transmitted. While very common overall, only a small proportion of infected individuals develop visible warts. In women, they are commonly found on the vulva, but can also line the vagina and occur on the cervix, as well as being perianal. While they can occur around or even inside the urethral meatus, the source lists them here generally as a potential abnormality. We'll discuss them in more detail later under infections.
Okay, noted here as a possible finding. Finally, carcinoma of the female urethra. How common is this?
Carcinoma of the urethra actually occurs twice as often in women as in men, although it's still relatively rare overall. It's debated whether a caruncle can become malignant, but they are often found in close proximity. A clinical clue is that malignant swellings of the urethra feel harder on palpation than benign ones like caruncles.
How is female urethral carcinoma
The
treated?
treatment is either by radiotherapy or radical surgery, depending on the stage and location.
And the prognosis?
The overall prognosis for carcinoma of the female urethra is unfortunately poor, often because it's diagnosed at a later stage.
That covers the conditions specifically noted for the female urethra. Let's now move outwards and look at conditions affecting the foreskin, a structure unique to uncircumcised males.
An area with several common issues. We'll start with phimosis.
Phimosis is the inability to retract the foreskin over the glands, but the source makes an important distinction regarding boys, calling it physiological phimosis. What's that about?
Yes, this is key to avoid unnecessary treatment or parental anxiety. At birth, there are normal physiological adhesions between the inner foreskin and the glans penis. These adhesions gradually release over time, beginning around age 2 and sometimes persisting naturally until age 6 or even later. This normal developmental stage gives a false impression of phimosis, but the source emphasizes that this is not true phimosis and requires no treatment. Forcible retraction should definitely be avoided.
So normal infant anatomy isn't necessarily a problem needing intervention. Good to know. What's true phimosis in boys then?
True phimosis is when the prepuce genuinely cannot be retracted over the glands beyond the natural developmental stage. Figure 85.33 shows a tight opening. This can lead to issues like ballooning of the foreskin during maturation, as urine accumulates temporarily beneath it, and can predispose to infection of the glands and foreskin, called balanopustitis. Symptomatic true phimosis in boys typically requires circumcision.
And phimosis in adults, is that also developmental?
In adults, phimosis is almost always acquired, resulting from scarring. This scarring is commonly caused by recurrent episodes of balanitis, inflammation of the glands, or posthitis, inflammation of the foreskin, or specifically by lichen sclerosis, LS. As we discussed with strictures, LS causes dense fibrosis. In the foreskin, figures 85.14 and 85.15 show the whitish scarring. It makes the tissue thickened and inelastic, often whitish, forming a tight constricting band that prevents retraction.
Making hygiene difficult.
Yes, exactly, and leading to recurrent balanitis attacks. Phimosis in adults caused by this kind of scarring requires circumcision.
So, true phimosis in boys and adults from scarring often leads to circumcision. Is there an emergency treatment for phimosis if someone needs a catheter or something?
Yes, in acute situations, such as when you need to access the glands for examination or insert a urinary catheter, but the phimotic foreskin cannot be retracted, a dorsal slit can be performed under local anesthesia. This involves making an incision along the top dorsal midline of the foreskin to release the constriction. It's a quick fix for access.
A quick fix for access. Let's discuss circumcision more broadly. It has a long history.
It certainly does. The source mentions it has been practiced since as early as 4000 BC. However, from a medical standpoint, it's important to note when it should not be performed: in the presence of hypospadias, penile curvature, or buried penis. These conditions might require the foreskin tissue for reconstructive procedures.
We covered not doing it with hypospadias earlier. What are the medical indications for circumcision according to the source?
In infants and young boys, it's frequently performed for social or religious reasons at the parent's request. Medical indications include true phimosis, causing symptoms, lichen sclerosis, though rare before age 5, recurrent attacks of balanoposthitis, and recurrent UTIs, especially when associated with other urinary tract abnormalities like high-grade vesicoureteral reflux.
And for adults?
In adults, indications include inability to retract the foreskin for comfortable intercourse, for symptomatic splitting of an abnormally tight frenulum, or for recurrent balanitis.
The source also mentions a public health dimension to circumcision relating to HIV.
Yes, there is emerging evidence suggesting that circumcision may offer protection against the spread of human immunodeficiency virus, HIV. The theory is that the virus dies more quickly on a dry, keratinized surface of a circumcised penis compared to the moist environment under the foreskin where it might survive longer. The source mentions large-scale adolescent circumcision programs under the World Health Organization in some African countries based on this potential benefit.
A notable public health angle. What about the basic surgical technique described in the source? How is it done?
The source briefly outlines the key steps, figure 85.16. Under anesthesia, the foreskin is held, a circumferential incision is made near the coronal sulcus, a dorsal slit extends this incision, and the inner layer is separated from the glands. This separation could be difficult in LS cases. A second circumferential incision removes the inner foreskin layer, leaving a small cuff. Vessels are secured, particularly the frenular vessels, and the skin edges are approximated with sutures. The source notes that the excised foreskin in LS cases should always be sent for histological examination. Summary box 85.6 reiterates common reasons for circumcision, distinguishing physiological from symptomatic phimosis.
A clear overview of the procedure and its indications. Now, related to the foreskin but distinct from phimosis is a short frenulum. What is that?
Yes, the source emphasizes that phimosis should not be confused with this condition. This is when the band of tissue connecting the underside of the glands to the prepuce, the frenulum, is unusually short or tight.
How does a short frenulum present? What problems does it cause?
It typically causes pain when the foreskin is retracted, particularly during sexual activity. Another common presentation is tearing of the frenulum during intercourse, which can be painful and cause bleeding.
Ouch, treatment.
It is treated surgically by frenuloplasty, a procedure to lengthen the frenulum. The source notes this utilizes the Heineke-Mikulec principle, a surgical technique of making an incision along the tight band and closing it transversely to gain length.
Lengthening that band of tissue. Next, paraphimosis. The source flags this as a surgical emergency. Why?
It is indeed a surgical emergency requiring urgent attention. Paraphimosis occurs when a tight foreskin has been retracted behind the glands and becomes trapped, unable to be returned to its normal position covering the glands.
What are the consequences of it being trapped back there?
The tight ring of foreskin behind the glands acts as a tourniquet, obstructing venous and lymphatic return from the glands and the distal foreskin. This causes rapid swelling, edema, of these tissues, which in turn increases the pressure exerted by the trapped prepuce ring, making it even more difficult to reduce. Figure 85.7c clearly shows the swollen, trapped glands. It can look quite alarming.
So, a vicious cycle of swelling and constriction. How is this treated urgently? Can it be fixed without surgery?
Treatment aims to reduce the swelling and return the foreskin to its normal position. Gentle manual compression of the glands can help reduce the edema, sometimes allowing the foreskin to be manually pulled back forward. The source also mentions injecting a solution of hyaluronidase and normal saline into the swollen tissue to help reduce swelling.
And if that doesn't work?
In emergency situations where manual reduction fails, a dorsal slit of the prepuce under local anesthesia may be performed to release the constriction immediately. Following successful reduction, circumcision is often recommended later to prevent recurrence.
Manual reduction, injections, emergency cut, or ultimately circumcision to prevent it happening again. Finally, balanoposthitis. What is that exactly?
Balanitis is inflammation of the glans penis, while posthitis is inflammation of the prepuce or foreskin. Since the opposing surfaces are often inflamed together, the term balanoposthitis is commonly used. Figure 85.18 shows inflammation.
What are the clinical features and how is it treated?
Mild cases present with itching and some discharge. In more severe inflammation, the glands and foreskin become red and raw, and pus may exude from under the foreskin. Treatment involved broad-spectrum antibiotics and local hygiene measures. The source notes it is particularly common in patients with diabetes, as high blood sugar can encourage infection. Recurrent vaginoposthitis often requires circumcision, especially in adults, to remove the inflamed foreskin and improve hygiene.
That covers conditions of the foreskin. Let's now move on to injuries directly affecting the structure of the penis itself, beyond the urethra.
Right, moving beyond urethral injuries, which can be associated, to trauma impacting the penile shaft tissues. First, avulsion of the skin of the penis.
Avulsion meaning the skin is torn away. That sounds awful.
Exactly. The usual causes described are mechanical: entanglement of clothing in rotating machinery, or sometimes severe zip injuries.
That sounds devastating. How are these injuries treated?
If it's a partial avulsion, the remaining skin can often be repaired surgically. If there's a complete avulsion of the penile skin, the source outlines two primary treatment strategies. A two-stage procedure can be performed. The first stage involves burying the denuded penis in the scrotum, allowing the scrotal skin to adhere and form a temporary covering. In the second stage, the penis is lifted, and the scrotal skin provides the new skin cover.
Burying the penis in the scrotum. A remarkable reconstructive approach. What's the alternative?
An alternative is initial surgical debridement to clean the wound, followed by skin grafting at a later stage, using skin taken from elsewhere on the body.
Okay. What about something called a fracture of the penis? Can the penis actually break?
Yes, although it's not a bone fracture. This is a specific type of injury that occurs when the erect penis is subjected to sudden, forceful bending, often during sexual activity.
So it can fracture. What exactly is breaking or rupturing?
It results in a rupture of the tunica albuginea. This is the tough, fibrous sheath that surrounds the corpora cavernosa, the two main erectile bodies of the penis. When this sheath ruptures under pressure, there is extravasation leakage of blood from the erectile tissue out into the surrounding penile shaft.
So it's a rupture of the erectile tissue covering, not a bone breaking. How do patients typically describe this injury? What do they feel or hear?
Patients usually report feeling or hearing a distinct cracking or popping sound at the time of the injury. This is immediately followed by intense pain and rapid detumescence loss of the erection. Clinically, there is visible bruising and a penile hematoma, a collection of blood under the skin, often resulting in a characteristic eggplant deformity where the penis is swollen, bruised, and deviated. Figure 85.19 shows this. There may occasionally be an associated urethral injury, so signs like blood at the meatus should be checked for.
A cracking sound, immediate pain, and detumescence, very distinctive symptoms. How is it investigated and managed? Is it urgent?
Investigations can include ultrasound and MRI to assess the extent of the tunica albuginea rupture and hematoma. The management is surgical and emphasizes early exploration of the penis with surgical repair of the ruptured tunica albuginea. Prompt repair minimizes scarring, helps prevent future curvature, and preserves erectile function better than delayed repair. So yes, it's considered urgent.
Repairing that torn sheath as soon as possible. Finally, strangulation of the penis. What causes that?
This is caused by placing constricting objects, most commonly rings, on the base of the penis, usually for sexual pleasure or sometimes accidentally.
And the consequence?
The constriction impedes venous return from the penis, leading to venous engorgement and swelling distal to the ring, which then makes it impossible to remove the ring.
The swelling makes the ring tighter, making the swelling worse. A dangerous cycle.
Exactly. The source is very clear on the treatment. The ring must be cut off, usually requiring specialized ring cutters designed for this purpose, to relieve the venous congestion and prevent permanent damage to the tissue from lack of blood flow. This needs to be done urgently.
Urgent removal of the constricting ring. That covers direct physical injuries to the penis. Let's now move to other abnormalities that affect the form or function of the penis beyond trauma. A big topic here is erectile dysfunction.
A major topic indeed, commonly known as ED.
A very prevalent issue. How does the source define ED?
ED is defined as the consistent inability to attain or maintain an erection firm enough for satisfactory sexual intercourse.
And what are the main causes listed in the source? Is it mostly psychological?
While psychological issues can certainly contribute or be the primary cause in some men, the source states that the commonest cause of ED, particularly as men age, is vascular disease, affecting penile arterial blood flow. As such, ED is strongly associated with systemic vascular risk factors like diabetes, hypertension, dyslipidemia, high cholesterol, and smoking.
So, factors that are bad for overall heart health are often bad for erectile function. They're linked.
Precisely. In fact, the source explicitly notes that ED may serve as an early marker of underlying cardiovascular disease. So if a man develops ED, it's a prompt to check his overall cardiovascular health. Other causes include endocrine diseases like hypogonadism, low testosterone, or prolactin-secreting pituitary tumors, and neurological diseases such as multiple sclerosis, spinal cord injury, or prolapsed intervertebral disc affecting the nerve pathways essential for erection.
Neurological issues make sense, given the dependence on nerve signals. What about medical treatments causing ED?
Yes. There are also iatrogenic medically caused causes, including damage to the caronosal nerves from radical pelvic surgery like radical prostatectomy for cancer, abdominoperineal excision of the rectum, or radical cystectomy for bladder cancer. Neuropathy secondary to pelvic radiotherapy is another iatrogenic cause. Lastly, various medications can induce ED, including certain antihypertensive agents, antidepressants, and antipsychotics. It's quite a long list of potential culprits.
A wide range of potential causes, but emphasizing vascular health is key. How is ED typically assessed? What tests are done?
Assessment involves a physical examination, including the genitalia, measurement of blood pressure, and assessment of secondary sexual characteristics. Biochemical assessment is necessary in all cases, including blood sugar, serum lipid profile, and serum testosterone levels to check for underlying conditions like diabetes, high cholesterol, or low testosterone. A key specific investigation is penile Doppler ultrasound, usually performed after an intracavernous injection of a vasoactive agent like papaverine to induce an erection. The Doppler then evaluates the velocity and characteristics of blood flow in the penile arteries.
So, checking systemic health markers and directly assessing penile blood flow. What are the treatment options outlined? Where do you start?
Treatment typically follows a stepwise approach. The first-line therapy for ED is usually oral phosphodiesterase type 5, PDE5 inhibitors, such as sildenafil, Viagra, tadalafil, Cialis, or vardenafil, Levitra. These are often very effective.
Oral medications are the initial approach. What are the options if these aren't effective or suitable for a patient?
Other options include self-intracavernosal injection of vasoactive agents. The patient learns to inject medication directly into the erectile tissue to achieve an erection. Vacuum erection devices are a non-invasive alternative that draw blood into the penis. And penile implants, which the source mentions are becoming increasingly popular, are a surgical option for men who don't respond to or can't use other treatments. There are two main types: semi-rigid, malleable, and inflatable. Summary box 85.7 summarizes the ED points. Investigate vascular risk factors, PDE5 inhibitors first line, implants increasingly popular for refractory cases.
Penile implants is a final but effective option. That covers the assessment and treatment of ED. Now let's look at conditions affecting the shape of the penis, starting with Peyronie's disease, or PD. What is that?
Peyronie's disease, named after the physician who described it, is characterized by a combination of symptoms: penile deformity, typically a bend or curvature of the erect penis; palpable penile plaques, hardened areas inside the penis shaft; sometimes ED; and sometimes pain on erection, especially in the early stages.
What is believed to cause Peyronie's disease? Is it an injury?
The exact cause is unknown. However, the probable mechanism outlined is that minor trauma to the erect penis, perhaps during sexual activity that goes unnoticed, leads to secondary microhemorrhage, tiny areas of bleeding beneath the tunica albuginea, that tough fibrous sheath of the corpora cavernosa. This bleeding then heals abnormally by fibrosis, forming the palpable plaques that can be felt. These plaques may, in rare cases, become calcified, appearing as hard areas. Figure 85.21 shows a calcified plaque on MRI.
So minor injury leading to scarring and plaque formation. How does the plaque cause the bend or deformity?
The plaques are relatively inelastic compared to the surrounding tunica albuginea. When the penis becomes erect and the corpora cavernosa fill with blood and expand, the area with the inelastic plaque cannot expand as much as the healthy tissue. This causes the erect penis to bend towards the side where the plaque is located. The deformity is commonly dorsal, meaning it bends upwards towards the abdomen, but it can bend in any direction depending on plaque location. A significant bend can mechanically prevent penetrative sexual intercourse.
I see how that would affect function. The source also notes an association with another condition affecting the hands.
Yes, there is a noted association with Dupuytren's contracture, a condition involving fibrous contractures on the palm of the hand and fingers, causing them to bend inwards. It seems there's a link between these fibrotic conditions.
An interesting link between fibrotic conditions in different parts of the body. What's the natural progression of Peyronie's disease? Does it keep getting worse?
The source notes that the condition typically goes through an active phase, where the curvature and pain may worsen, usually lasting for 18 to 24 months. After this active phase, the condition typically stabilizes, meaning the curvature doesn't progress further and pain often resolves. During the active phase, surgery is not indicated as the condition is still changing.
Are there effective medical treatments for the active phase?
A variety of medical treatments have been tried, including oral medications and injections, but the source states that none have shown good evidence of significant benefit in altering the natural history or reliably reducing curvature during the active phase.
So wait for it to stabilize before considering surgery. How is it diagnosed?
Diagnosis is usually made clinically based on the patient's history, the palpable plaques, and observation or documentation, for example, photos of the penile curvature during erection. MRI may be helpful in some cases to visualize the plaques or assess for active inflammation, but isn't always necessary.
And newer treatments mentioned, like
Sure.
injections.
The source mentions newer treatments, including intralesional injections of collagenase Clostridium histolyticum, GFX, an enzyme injected directly into the plaque to try and break down the fibrous tissue and reduce curvature. This is an option for some men in the stable phase.
Injections into the plaque. When is surgery indicated, and what are the surgical options once the condition is stable?
Surgical correction is considered in the chronic stable phase only if the penile deformity is significant enough to interfere with sexual activity. There are two main surgical approaches. If the penis is of adequate length despite the curvature, a plication procedure can be performed. This involves surgically folding or sticking the tunica albuginea on the side opposite to the maximum curvature, effectively shortening the longer side to straighten the bend. Techniques include Nesbit's technique or the 16-dot plication technique.
Shortening the unaffected side to compensate for the plaque. What's the second surgical option, maybe if the penis is shortened by the disease?
The second option involves incision or excision of the plaque itself, and using a graft material to fill the defect created and allow the penis to straighten and potentially regain some length. A common graft material mentioned is a bovine pericardial patch, tissue derived from cow heart sac. Summary box 85.8 highlights key aspects. Active vestibular phases, no proven medical treatment in active phase, surgery in stable phase if deformity affects sex. Options are application or incision with grafting.
Different surgical strategies based on factors like length and the severity of the plaque. Related to this, the source mentions congenital curvature of the penis. How is that different?
This is a penile deformity that is present from birth and is occasionally seen in young men. Figure 85.22. It's described as being similar and analogous to Peyronie's disease in that it causes a penile bend during erection.
What are the key differences from Peyronie's disease?
Unlike Peyronie's, it's present from birth, not acquired later in life, and there's no palpable plaque. The source also notes that the urethral length is normal in congenital curvature. The typical deformity in congenital curvature is a ventral bend, a downward curvature of the erect penis, whereas Peyronie's is often dorsal, upward, although that can vary.
So present from birth, no plaque, normal urethra, and typically a downward bend. How is it treated?
If the deformity is significant enough to interfere with sexual activity, surgery is performed to straighten the erect penis. This typically involves a plication procedure, similar to the Nesbit procedure used in Peyronie's disease, shortening the longer dorsal side.
Surgical correction if needed for function. Finally, a condition the source explicitly calls a surgical emergency. Priapism. Remind us what that is.
It is crucial to recognize priapism as a surgical emergency. The definition provided is a persistent erection lasting longer than 4 hours, unrelated to sexual stimulation.
Longer than 4 hours is the critical threshold, and there are two main types.
Yes, the source distinguishes between ischemic priapism and non-ischemic priapism. They're very different.
Let's start with ischemic priapism, which is the more common type. What's the mechanism?
Ischemic priapism is also known as veno-occlusive or low-flow priapism. It's caused by venous congestion, meaning blood gets trapped in the erectile tissue, corpora cavernosa, and cannot drain properly. This congestion leads to thrombosis, blood clots forming, and ischemia, a lack of oxygen and blood flow to the tissue.
What does this feel like for the patient? Is it painful?
Yes, the penis remains erect and becomes progressively painful and rigid. This is described as a pathological erection. An important clinical detail is that the glans penis and corpus spongiosum, the underside containing the urethra, are typically not involved. They remain soft. The rigidity and pain are confined to the corpora cavernosa of the shaft.
So a hard, painful shaft, often with the softer glands. What causes this trapped blood and ischemia?
The most common causes are side effects of certain medications, notably some antipsychotic medications and intracavernosal injections used to treat ED. Could also arise as a complication of hypercoagulable blood disorders, conditions where the blood clots too easily, such as sickle cell disease or leukemia. In a small proportion of cases, it can be caused by malignant disease infiltrating the corpora cavernosa or the pelvis.
How is ischemic priapism diagnosed definitively?
Blood aspirated directly from the corpora cavernosa of the penis will show characteristics of ischemia. It will be dark, hypoxic, low oxygen levels, hypercapnic, high carbon dioxide levels, and acidotic, low pH. Doppler scanning of the penile arteries and veins is also used and will show an absence or very low flow of blood within the corpora cavernosa, confirming the veno-occlusive nature.
Then why is the time factor, that 4-hour mark, so critical? What happens if it's left longer?
The source strongly emphasizes that delay beyond 6 hours results in progressive, irreversible damage to the corpora cavernosa tissue due to prolonged lack of oxygen. This ischemic damage leads to subsequent fibrosis, scarring, and permanent erectile dysfunction. Therefore, it's a true emergency requiring prompt specialist urological care to exclude underlying causes and initiate treatment to achieve detumescence. Summary box 85.9 highlights the key features: painful erection not involving the glands, blood gas findings, hypoxic, acidotic, and the critical need for detumescence ideally within 6 hours to preserve function.
6 hours is the critical window to intervene and minimize long-term damage. What is the treatment for ischemic priapism? What do they do?
The first-line treatment is aspiration of the sludged, deoxygenated blood from the corpora cavernosa, often followed by irrigation with saline. If aspiration alone is insufficient, the next step is intracavernosal injection of phenylephrine, an alpha-adrenoceptor agonist that helps constrict blood vessels and promote venous outflow.
And if those measures are ineffective?
If these measures fail, surgical intervention may be necessary to decompress the penis by creating a shunt, an artificial connection between the corpus cavernosum and either the glans penis, corporogranular shunt, or the corpus spongiosal shunt to allow the trapped blood to drain out.
So first try to drain the blood, then try medication to constrict vessels, and if all else fails, create a surgical bypass. And if treatment is significantly delayed, say over a day.
The source states that treatment initiated after 24 to 36 hours rarely restores normal erectile function, highlighting the permanent damage that can occur with prolonged ischemia. The source also mentions a recurrent form of ischemic priapism, sometimes called stuttering priapism, which is particularly seen in patients with sickle cell disease presenting with repeated shorter episodes.
That covers the more common, painful ischemic type. What about the non-ischemic priapism? How is that different?
This is a rarer form of priapism, also called high-flow priapism. It typically arises as a consequence of traumatic damage to the central penile artery, usually from blunt perineal trauma, like the straddle injuries we discussed earlier, or sometimes penetrating injury.
So a different cause and mechanism related to trauma. How does trauma lead to this type?
The trauma creates a fistula, an abnormal connection between the damaged arterial vessel and the sinusoidal space within the corpus cavernosum. This results in uncontrolled high-pressure arterial blood flowing directly into the erectile tissue, causing a persistent erection.
So too much blood flowing in rather than blood being trapped, and the key symptom difference compared to ischemic.
In contrast to ischemic priapism, this non-ischemic high-flow priapism results in a persistent erection that is typically painless and often not fully rigid.
Painless erection, high flow. How is this diagnosed?
Blood gas analysis of blood aspirated from the penis will show characteristics of arterial blood, high oxygen, normal pH. Doppler scanning and selective arteriography, an X-ray imaging technique using contrast injected into the arteries, will demonstrate the presence and location of the arteriovenous fistula.
And treatment for this high flow type, is it as urgent?
It's not usually considered an emergency requiring immediate detumescence like the ischemic type, as there isn't the same risk of tissue damage from lack of oxygen. Treatment may initially involve observation or androgen ablation therapy. If medical therapy fails or isn't appropriate, selective arterial embolization is performed. This involves using image guidance to pass a catheter into the artery supplying the fistula and injecting material to block off the abnormal connection, stopping the high flow.
Two distinct types of priapism: ischemic, painful, low flow, emergency, and non-ischemic, painless, high flow, less urgent, with different causes, diagnosis, and treatment approaches. That covers abnormalities of form and function. Now, let's move to the serious topic of malignancy: carcinoma of the penis.
Carcinoma of the penis is a significant but less common malignancy compared to many other cancers, particularly in Western countries.
What are the main causes and risk factors outlined in the source? Is circumcision protective?
Yes, a major protective factor is neonatal circumcision. Circumcision performed soon after birth confers a high degree of immunity against carcinoma of the penis. The source notes that later circumcision does not seem to have the same protective benefit, possibly related to the historical assumption that smegma, which can accumulate under an intact foreskin, may be carcinogenic, or perhaps related to early exposure to HPV.
So early circumcision is linked to lower risk. What about infectious causes, HPV?
Yes, infection with high-risk human papillomavirus HPV types, specifically types 16 and 18, is a known risk factor, similar to cervical cancer.
And other conditions or habits?
Lichen sclerosis, LS, that chronic inflammatory condition, and smoking are also identified as risk factors. Phimosis, non-retractile foreskin, and chronic belinoposthitis, inflammation, are considered contributory factors, likely due to chronic irritation, poor hygiene, and potentially trapping carcinogens or promoting HPV persistence.
The source also mentions precancerous states. What are they?
Yes, there are recognized precancerous conditions that can develop into invasive cancer if left untreated. These include leukoplakia of the glands, appearing as white patches, similar to a condition seen on the tongue, and penile intraepithelial neoplasia, PIN. Figure 85.23 shows an example of early cancer, potentially associated with LS.
What are the key investigations used to diagnose and stage penile cancer?
The most essential step for diagnosis is a biopsy of any suspicious lesion. MRI is performed for local staging, assessing the depth of invasion into the penile structures like the corpora. Assessment of the local regional lymph node status, particularly the inguinal nodes in the groin, is also considered essential for staging and planning treatment, as spread to nodes drastically changes prognosis.
Biopsy for confirmation, MRI for local extent, and check the lymph nodes for regional spread. You mentioned penile intraepithelial neoplasia, or PIN. Can you explain that a bit more?
PI is essentially carcinoma in situ of the penis. Cancer cells are present but confined to the surface layer, epithelium, and haven't invaded deeper into the underlying tissues. It's also known by historical terms like Bowen's disease when occurring on the shaft and erythroplasia of Querot when occurring on the glands.
What does PIN look like clinically?
PIN is typically seen as a persistent red, sometimes velvety cutaneous patch on the penis.
A persistent red patch should raise suspicion. How is it diagnosed definitively?
Since other benign conditions can cause red patches, like inflammation or fungal infections, a biopsy is indicated whenever there is clinical doubt to confirm the diagnosis of PIN. You can't just assume it's benign.
And if PIN is confirmed, how is it treated? Can it be cured?
Treatment options for carcinoma in situ include topical 5-fluorouracil cream, a chemotherapy cream, CO2 laser ablation, or surgical excision. These aim to remove or destroy the abnormal surface cells and are often curative at this early stage.
Moving to invasive squamous cell carcinoma, what is the typical pathology and growth pattern?
Squamous cell carcinoma is the most common type of penile cancer, typically arising from the skin of the glands of the prepuce. Figure 85.24 shows a typical ulcerative lesion. It can appear as a flat infiltrating lesion, often developing from leukoplakia or PIN, or as a warty exophytic growth, potentially developing from an existing papilloma. Local growth tends to be slow, progressing over months or years before spreading.
How is the local extent of the cancer staged? Using the T stage?
Yes, the source describes T staging based on the depth of invasion. T1 is confined to the subepithelial connective tissue just below the skin. T2 invades the corpus spongiosum, or corpora cavernosa. T3 invades the urethra, and T4 invades adjacent structures like the prostate or pubic bone.
And how does it typically spread beyond the penis? Lymph nodes first?
Yes, the earliest spread is typically lymphatic. It spreads first to the inguinal lymph nodes in the groin, classified as N1 and N2 disease, depending on number and fixation. From the inguinal nodes, it can then spread further up to the iliac nodes in the pelvis, N3 disease. Distant metastatic deposits via the bloodstream are infrequent compared to lymphatic spread, especially early on.
What are the common clinical features when patients present with penile cancer? Do they come in early?
Unfortunately, many patients present late, often with a large, fungating like a fungus, or ulcerative growth, figure 85.24, frequently due to embarrassment or misdiagnosis. About 10% of patients are under the age of 40, so it's not exclusively a disease of the elderly.
What are the signs? Is it painful?
By the time of presentation, growth is often large, and secondary infection is common, leading to a foul-smelling bloody discharge. There is typically surprisingly little or no pain, which can contribute to delayed presentation.
Little pain, even with a large growth, a reason it might be ignored. What about the lymph nodes at presentation? Are they usually enlarged?
Around 50% of patients have enlarged inguinal lymph nodes at presentation. However, the source makes a crucial point here. Nodal enlargement frequently reflects secondary infection in the primary tumor site, not necessarily metastatic spread of the cancer. So enlarged nodes need further assessment and shouldn't automatically be assumed to be cancerous.
Important distinction for management. How is the penis examined if the foreskin is phimotic or non-retractile?
If the prepuce is non-retractile and hiding the lesion, it must be split surgically, dorsal slit, to allow clear visualization of the lesion. And again, a biopsy must be performed to confirm the diagnosis. Clinical appearance alone isn't enough.
What is the typical course if penile cancer is left untreated?
Untreated, the local growth continues, potentially destroying and replacing the entire glands and invading deeper structures. Later, cancerous inguinal nodes can enlarge massively and erode through the skin of the groin, creating painful ulcerated masses. In rare cases, death can result from the growth eroding into major blood vessels like the femoral or external iliac vessels, causing catastrophic hemorrhage.
A severe and devastating untreated course. How is penile cancer treated? It sounds like surgery is key.
Management is divided into treating the primary tumor on the penis and managing the inguinal lymph nodes. For small, superficial lesions of low grade and low stage, organ-preserving surgery is often possible. This includes limited excision, Mohs micrographic surgery, or laser ablation.
Mohs surgery, what is that technique exactly?
Mohs surgery is a micrographic technique involving sequential excision of tissue layers under repeat microscopic control during the operation. This allows for precise identification of the tumor margins while preserving as much healthy tissue as possible, which is particularly valuable in preserving function and appearance in locations like the penis.
Removing the cancer layer by layer with microscopic checks to save tissue? Very precise.
Yes. However, for most invasive primary tumors, surgical excision remains the mainstay. The source notes a shift in approach from traditionally advocating for a wide 2-centimeter margin of normal tissue to a more conservative, penis-preserving approach with much smaller margins, even a few millimeters, now being accepted for many cases, provided the cancer is completely removed histologically.
More tissue preservation where possible. What are the surgical options for more advanced primary tumors?
Tumors limited to the glands can often be treated with glandsectomy removal of the glands, often with skin grafting for reconstruction. More advanced tumors invading the shaft may require partial penectomy removal of a portion of the penis. In very advanced cases involving the base, total penectomy is necessary with the creation of a perineal urethrostomy, where the urethra is brought out to the skin in the perineum for urination.
Is surgery still done even if the cancer has already spread?
The source notes that these more radical surgical techniques for the primary tumor are indicated even in the presence of advanced metastatic disease for reasons of local control to manage the primary tumor growth, prevent pain, bleeding and infection, and improve quality of life.
Surgical approaches tailored to the extent of local invasion. How are the inguinal lymph nodes managed? You said they might be enlarged due to infection.
Management of enlarged inguinal nodes requires careful timing. Treatment of the nodes should be delayed for at least 3 weeks after initiating local treatment of the primary lesion and giving antibiotics. This allows time for any inflammation-related swelling in the nodes to subside, so you can better determine if the enlargement is due to infection or cancer spread.
Okay, wait and see if they shrink with antibiotics first. What if they remain palpable?
For palpable nodes that persist after this period, ultrasound-guided fine needle aspiration, FNA, or core biopsy is performed to confirm malignancy. If cancer is confirmed, a bilateral inguinal lymph node dissection, removing the lymph nodes in both groins, is usually undertaken.
Removing the nodes if they are palpable and confirmed to contain cancer. What about nodes that aren't palpable on examination? Is there still a risk of microscopic spread?
Yes, there is. For clinically non-palpable inguinal nodes, CN0, management involves dynamic sentinel lymph node biopsy, SLNB. This involves injecting a radioactive tracer and/or blue dye near the primary tumor site, identifying the first lymph nodes that drain that area, the sentinel nodes, using a gamma probe or visually, and surgically removing just those nodes for detailed histological examination.
So checking the first nodes in the drainage pathway before doing a full dissection.
Exactly. If the sentinel node biopsy is positive, indicating microscopic regional spread, then a full bilateral inguinal node dissection is performed. If the sentinel nodes are negative, the patient can usually be observed, avoiding the morbidity of a full node dissection.
What about pelvic lymph nodes further up?
Management of pelvic lymph nodes, which are further up the lymphatic chain, is controversial. If they are clearly involved on CT scanning, surgery probably has limited benefit in terms of cure, though sometimes chemotherapy is used. However, when the iliac pelvic nodes do not appear enlarged on CT despite evidence of N2 disease, significant inguinal node involvement, options mentioned include observation, pelvic lymphadenectomy, surgical removal of the pelvic nodes, or radiotherapy to the pelvis.
Is chemotherapy generally effective for penile cancer?
The source states that chemotherapy is relatively ineffective for curing penile cancer and is currently reserved mainly for palliation in those with distant metastatic disease, or sometimes used neoadjuvantly before surgery for bulky nodal disease. Summary box 85.0 provides key points. Enlarged and inguinal nodes may be infection or spread. Biopsy confirms diagnosis. Surgery is the mainstay of treatment. SLNB guides management of clinically negative nodes, and nodal involvement significantly worsens prognosis.
What is the overall prognosis for penile cancer? Does node involvement make a big difference?
The prognosis is highly dependent on whether the cancer has spread to the lymph nodes. For tumors confined to the penis, node negative, the prognosis is generally good, with 5-year survival rates exceeding 80%. However, with confirmed nodal involvement, the 5-year survival rate falls significantly to around 40% or even lower depending on the extent.
That highlights the critical importance of early diagnosis and managing potential nodal spread. Are there any other less common penile cancers mentioned?
Yes, the Buschke-Lowenstein tumor is mentioned. This is uncommon. It has the histological pattern of a verrucous carcinoma, often associated with HPV. It's characterized by being locally destructive and invasive, growing quite large, but it appears not to spread to lymph nodes or metastasize distantly. Treatment is primarily by surgical excision.
Aggressive locally, but doesn't metastasize. What about malignant melanoma of the penis?
This is also an uncommon tumor of the penis. The principles of management are generally the same as for squamous cell carcinoma, involving surgical excision and nodal assessment. However, the source notes that blood-borne metastatic disease spread via the bloodstream to distant organs is more common with malignant melanoma than with squamous cell carcinoma of the penis.
So, a higher risk of distant spread via the blood with melanoma. That concludes our detailed look at carcinoma of the penis. Let's move now to a range of conditions caused by infections and inflammation, many of which are sexually transmitted.
A large and clinically important category. We'll cover several key conditions here. Let's start with a very severe and rapidly progressing infection. Fournier's gangrene.
Fournier's gangrene. That term immediately sounds serious, like something you don't want to get.
It is. It's extremely serious. Fournier's gangrene is a progressive necrotizing infection affecting the genitalia and perineum. Figure 85.25 shows a clinical example. It's essentially a type of necrotizing fasciitis, sometimes called flesh-eating bacteria, specifically affecting this area.
What causes this aggressive infection? Is it one specific bacteria?
It's typically a polymicrobial infection, meaning it's caused by a mix of bacteria working together, commonly including organisms like Escherichia coli, various bacteroid species, anaerobes, Streptococcus pyogenes, and Staphylococcus aureus. It's often a synergistic infection.
Are there specific conditions or risk factors that make someone more susceptible to developing Fournier's?
Yes, it is often associated with underlying conditions that compromise the immune system or tissue health, such as diabetes mellitus, very common association, cancer, malnutrition, chronic alcoholism, or recent urogenital or colorectal instrumentation or trauma that creates an entry point for bacteria.
What are the symptoms and signs, and how quickly does it progress? You said rapidly.
The hallmark of Fournier's gangrene is its rapid progression. It typically starts with symptoms and signs of cellulitis in the genital or perineal area, redness, swelling, intense pain, often out of proportion to the visible signs initially, and potentially blister formation, bullae. However, this quickly progresses, sometimes within hours, to foul-smelling necrotic lesions with dusky, dead-looking skin, indicating tissue death underneath. Crepitus, a crackling sensation under the skin due to gas produced by bacteria, might also be present.
Rapid progression to tissue death, and you called it a surgical emergency.
It is absolutely a surgical emergency. The infection progresses with extreme speed, spreading from the genitalia to the perineum and even up the abdominal wall rapidly along the fascial planes. There's a very high risk of bacterial septicemia, the infection spreading into the bloodstream, leading to systemic shock and multi-organ failure.
And the outcome, if this isn't treated immediately and aggressively?
The source is unequivocal. It will lead to death if untreated. Mortality rates, even with treatment, can be significant.
That emphasizes the critical urgency. How is Fournier's gangrene treated?
Treatment requires a combination of aggressive interventions, usually in an intensive care setting. This includes resuscitation with fluids, broad-spectrum intravenous antibiotics to target the mixed bacterial flora, and crucially, immediate and extensive surgical debridement. This means surgically removing all dead, damaged, and infected tissue until healthy, bleeding tissue is reached. This often requires multiple trips to the operating room.
Antibiotics and aggressive life-saving surgery often repeated. A true emergency. Let's move to a more common symptom related to infection, urethral discharge.
Urethral discharge, particularly in men, is most commonly caused by urethritis, which is inflammation of the urethra. The source identifies two commonest causes of urethritis: non-specific urethritis, NSU, and gonococcal urethritis.
What are other symptoms that might accompany urethral discharge from urethritis?
Besides the discharge itself, common associated symptoms include dysuria, painful or difficult urination, and urethral pruritus, itching sensation within the urethra. Epididymitis, inflammation of the epididymis, the structure behind the testicle, can also be present as a complication.
And what's a critical part of the assessment when evaluating urethral discharge? The history.
Yes, a detailed sexual history is essential. This should specifically inquire about recent sexual activity, number of partners, types of intercourse, including unprotected intercourse, oral sex, and anal intercourse, and any symptoms in partners to assess potential exposures to sexually transmitted infections, STIs.
What's the routine investigative screen for urethral discharge? What tests are done?
A routine diagnostic workup typically includes a gram stain of the discharge smear, looking for characteristic bacteria like gonococcus, dipstick testing and culture of a urine specimen, and importantly, nucleic acid amplification testing, NIT, of either a first catch urine specimen or a urethral swab. The source notes that if relevant exposures or symptoms suggest infection elsewhere, the same NATE techniques can be applied to samples from other sites like vaginal, endocervical, anal, or pharyngeal swabs.
NATE is highlighted as particularly useful. Why?
Yes, the source notes that NATE is a highly sensitive method for identifying both gonococcal and chlamydial urethritis, much more sensitive than older methods like culture for chlamydia. And as with all potential STIs, the possibility of other concurrent infections, such as HIV, syphilis, etc., should always be considered and tested for where appropriate based on risk factors.
Let's look closer at the two commonest causes of urethritis, starting with nonspecific urethritis, or NSU. What exactly is that?
NSU, also known as non-gonococcal urethritis, NGU, is classified as an STI and is actually the commonest cause of urethritis in the Western world.
What are the causes of NSU, given that it's called nonspecific? Does that mean we don't know?
Well, sometimes we don't identify a specific cause, but it's linked to several potential pathogens. In around 40% of cases, it's caused by chlamydia trachomatis, which is a very common STI. Other causative agents include ureaplasma urelyticum, Trichomonas vaginalis, a protozoan, or Mycoplasma genitalium. However, the source notes that the causative agent in up to 50% of cases remains unknown, hence the nonspecific label.
So chlamydia is a major culprit, but other organisms or unknown factors are involved. Does NSU affect both men and women, and are symptoms always present?
It affects both men and women, and importantly, asymptomatic infection is common in both sexes. This is a key public health issue, as people can transmit it without knowing they have it.
Meaning you could have it and not know. How does it typically present in men who do develop symptoms?
In symptomatic men, dysuria, painful urination, and a white mucopurulent urethral discharge usually appear up to 6 weeks after sexual intercourse. Dysuria is a common symptom. The urine may appear clear but can contain threads, small clumps of pus, or show pus cells on microscopy. Epididymitis is a common complication in men if it ascends. A potential late complication mentioned is urethral stricture, similar to what we discussed earlier, due to chronic inflammation and scarring.
So NSU can scar the urethra over time. How does it present in women? Is it also often silent?
Yes, in women, NSU is typically asymptomatic. However, it can manifest as vaginal discharge or as a form of urethrotrigonitis, inflammation of the urethra and bladder trigonaria causing urinary symptoms. It may also lead to cervicitis, inflammation of the cervix, or ascend to cause pelvic inflammatory disease, PID, which can have serious reproductive consequences like chronic pain, ectopic pregnancy, and infertility.
How is NSU diagnosed, especially given the potential for asymptomatic infection?
Excluding gonorrheal infection is an important step in diagnosis. The diagnostic test of choice is NATE, performed on a first catch urine specimen or urethral swab in men, or urine endocervical or vaginal swabs in women. If testing is positive, contact tracing is essential, and partners should be screened and treated.
And treatment for NSU, is it straightforward?
Standard treatment regimens involve antibiotics. Options recommended in the source include a single 1-gram dose of azithromycin or a 7-day course of doxycycline, 100 milligram orally twice daily.
Is treatment always curative, or is relapse common?
Treatment is usually effective, but relapse is noted as common, particularly in men, where the prostate may potentially act as a reservoir for the infection. Persistence or recurrence might also be due to reinfection from an untreated partner or infection with an organism not covered by the initial antibiotic, like Mycoplasma genitalium, which often requires different treatment.
Preventing reinfection seems key then.
Absolutely. It is important to treat all sexual partners simultaneously to prevent reinfection. Retesting of both partners at 3 months is recommended to ensure clearance and detect any reinfection.
That covers NSU. Now, the second commonest cause of urethritis, gonorrheal urethritis, what causes that?
Gonorrhea is a sexually transmitted disease caused by the bacterium Neisseria gonorrhea, often called the gonococcus. It's described as a gram-negative kidney-shaped diplococcus, meaning it appears as pairs of kidney-shaped bacteria under gram staining.
Where does gonorrhea infect the body? Just the urethra.
It primarily infects mucous membranes. In men, it commonly infects the anterior urethra. In women, it infects the urethra and cervix. It can also infect the oropharynx, throat, rectum, and anal canal in both sexes, but especially in men who have sex with men, depending on sexual practices. Transmission is primarily through unprotected sexual contact. It is the second commonest cause of urethritis in Western countries.
How does gonorrhea typically present in men versus women? Is it often asymptomatic, like NSU?
Actually, most men who contract gonorrhea develop symptoms relatively quickly within a few days of infection. These include urethral discomfort and a prominent urethral discharge, often described as thick and purulent, yellow-green, frequently accompanied by scalding dysuria, severe pain on urination. In women, however, gonorrhea is often asymptomatic. Maybe 50% or more have no symptoms. They may experience mild dysuria or a slight urethral discharge that goes unnoticed. Cervicitis is common, and about 10% of women with untreated gonorrhea will develop pelvic inflammatory disease, PID, specifically salpingitis, inflammation of the fallopian tubes, which, if bilateral, can lead to infertility.
A significant risk of infertility for women, even if they don't have obvious symptoms. That's worrying.
Yes. The source also mentions the risk of vertical transmission from an infected mother to her newborn during childbirth, which carries a risk of ophthalmia neonatorum, a severe eye infection in the baby that can lead to blindness if not treated promptly. In those exposed via oral or anal sex, gonococcal infections can cause a predominantly asymptomatic pharyngitis or proctitis.
How is gonorrhea diagnosed? Is it different from NSU?
Traditionally, diagnosis involved identifying pus cells and the characteristic gram-negative intracellular diplococci in a gram-stained urethral smear, with subsequent culture to confirm. However, more recently, NADI, which is more sensitive, has become the standard diagnostic method, often performed on the same urine or swab samples used for chlamydia testing.
Preventing complications is key. What can happen if gonorrhea isn't treated?
Absolutely. Effective early antibiotic treatment is crucial to prevent serious complications. In men, these include posterior urethritis, acute or chronic prostatitis, acute epididymoorchitis, periurethral abscess, and urethral stricture, a well-known historical complication. More unusual systemic complications mentioned include disseminated gonococcal infection leading to gonococcal arthritis, skin lesions, iridocyclitis, inflammation of the eye, septicemia, and endocarditis, infection of heart valves.
What is the current treatment for gonorrhea? Is resistance a problem?
Treatment is with antibiotics. The current treatment of choice recommended in the source is a combination therapy. Ceftriaxone, 250 milligrams administered intramuscularly, plus azithromycin, 1 gram taken orally. The combination is used to improve efficacy and potentially slow the development of resistance. The source notes increasing antibiotic resistance to older medications like ciprofloxacin or penicillin, making susceptibility testing important in some cases and highlighting the need for current recommended regimens.
Increasing resistance is a major concern in STI management. How is gonorrhea managed beyond just treating the patient?
Contact tracing is very important in controlling the spread of gonorrhea, notifying and treating partners. Management is usually overseen by a genitourinary medicine, GUM, or sexual health physician. Failure to respond to first-line treatment should raise the possibility of antibiotic resistance or co-infection with another organism like chlamydia.
That covers NSU and gonorrhea. Let's look at Reiter's disease, also known as sexually acquired reactive arthritis. What is this?
Reiter's disease is classified as an autoimmune disease. It's triggered by a prior infection, often an STI, but sometimes a gastrointestinal infection.
So, an infection somewhere else triggers an immune response that affects other parts of the body. What is the classic triad of symptoms?
Reiter's disease is characterized by the triad of urethritis, though this may be the triggering infection itself. Conjunctivitis, inflammation of the eye, and polyarthritis, inflammation of multiple joints, often asymmetric and affecting lower limbs. Skin lesions, keratoderma, blennorragicum can also occur.
What are the common triggering infections?
Common triggers include chlamydial urethritis, the most frequent trigger, less commonly gonococcal urethritis, and certain gastrointestinal infections causing diarrhea, such as salmonella, shigella, Yersinia, or campylobacter.
The source notes it's an HLA-B27 associated condition. What does that mean?
Yes, there's a strong genetic predisposition linked to the presence of the HLA-B27 gene, making individuals with this gene much more susceptible to developing this reactive arthritis after one of the triggering infections.
When do the eye and joint symptoms typically appear relative to the initial infection?
The conjunctivitis, which affects about 50% of patients, and the polyarthritis typically develop 1 to 3 weeks after the primary infection, such as the urethritis or diarrhea.
How is Reiter's disease diagnosed?
Diagnosis is primarily made on clinical grounds, based on the recognition of the characteristic pattern of symptoms, arthritis plus urethritis and the conjunctivitis, following a typical triggering infection, often in an HLA-B27 positive individual.
And treatment? Is it just treating the symptoms?
Treatment is largely symptomatic, focusing on managing the inflammation and pain in the joints and eyes using nonsteroidal anti-inflammatory drugs, NSAIDs, or sometimes stronger immunosuppressants. However, antibiotic treatment of the initial precipitating infection, if still active or recently diagnosed, like chlamydia, is also considered important.
What's the prognosis for Reiter's disease? Does it go away?
The urethritis and conjunctivitis often resolve within a few weeks. However, the arthritis can persist for months or even become chronic and recurrent in some individuals. Severe anterior uveitis, inflammation inside the eye, and frequently recurrent attacks suggest a less favorable long-term outlook.
Reiter's disease, an example of how STIs can trigger broader systemic autoimmune conditions. Let's look at periurethral abscess again, but focus on its infectious nature.
Periurethral abscesses were once common, often related to untreated gonorrhea causing infection in the periurethral glands, and were associated with high morbidity. According to the source, they are now relatively rare thanks to better STI treatment.
High morbidity implies they cause significant illness and complications. What are the current clinical presentations?
Clinical presentation can vary, but may include systemic symptoms like fever, along with local symptoms like dysuria, urethral discharge, and visible swelling or a tender lump along the course of the penis or in the scrotum perineum, depending on the location of the abscess.
And if left untreated, what can happen?
Untreated periurethral abscesses can lead to urethral fistulation, the formation of an abnormal opening from the urethra to the skin. Occasionally, they can progress to extensive cellulitis or necrotizing fasciitis, that severe flesh-eating infection we discussed with Fournier's gangrene, so still potentially very serious.
Where do these abscesses typically occur?
A penile periurethral abscess commonly arises following a gonococcal or chlamydial infection of one of the glands of litter, those small mucous glands lining the urethra. There may be a coexisting urethral stricture. Clinically, it presents as penile swelling with a tender hardened area, induration, felt on the underside of the penis, figures 85.26 AC. If untreated, it may spontaneously discharge pus externally, often leaving a persistent fistula. Ultrasound of the urethra can aid in diagnosis. Treatment involves both antibiotic therapy, similar to treating the underlying urethritis, and surgical drainage of the abscess, often into the urethra transurethral incision.
Infection of those small glands causing an abscess. What about abscesses further back in the bulbar urethra? Are they different?
An abscess in relation to the bulbar urethra is even less common. It may be associated with a urethral stricture, previous urethral trauma, or rarely, a urethral cancer. Infecting organisms are varied, including streptococci and anaerobic bacteria. Urine extravasation, urine leaking out of the urethra into the surrounding tissues, is not unusual. Symptoms are severe. Intense perineal pain, high fever, pyrexia, rigors, shaking chills, and tachycardia, rapid heart rate. Tenderness and swelling spread rapidly from the perineum to the penis and the anterior abdominal wall. It can mimic Fournier's.
Rapid spread and severe systemic symptoms, a serious presentation. Diagnosis and treatment for a bulbar abscess.
Ultrasound scanning and MRI are useful diagnostic aids to visualize the extent of the abscess. Figures 85.26 BC. Treatment requires prompt and aggressive intervention. Broad-spectrum antibiotics are essential. Collections of pus must be surgically drained, and it is crucial to divert urine away from the area by inserting a suprapubic urinary catheter.
Diverting the urine to protect the healing tissue. What about chronic abscesses?
A chronic periurethral abscess can sometimes develop as a result of a long-standing urethral stricture. Figure 85.26 shows complex fistulae potentially arising from this. The source notes that the multiple pockets of pus, loculi, should be drained, and the underlying urethral stricture must also be treated, often with urethroplasty later. Urethral fistulae can occur either spontaneously or as a result of surgical incision and drainage of the abscess.
That provides a detailed picture of infections and inflammation, including STIs and serious conditions like Fournier's. Let's focus specifically now on STIs that present as visible lesions, genital ulcers and warts.
Okay, starting with genital ulcers. The source states that the commonest cause of genital ulcers is genital herpes. Less common causes include syphilis and chancroid. And again, it's vital to remember that the presence of any genital ulcer requires consideration and testing for other STIs, including HIV. Don't just assume it's one thing.
So herpes is the most frequent cause of a genital ulcer. What causes it and what is the nature of the infection? Is it curable?
Genital herpes is caused by sexual transmission of the herpes simplex virus, most commonly HSV2, though occasionally HSV1, often associated with oral herpes. The nature of this infection is lifelong, unfortunately not currently curable. The virus resides latently in nerve ganglia and is capable of causing recurrent symptomatic outbreaks. Recurrent attacks occur in 50% or more of infected individuals, varying in frequency and severity.
Lifelong infection with potential for recurrence. What are the symptoms of an outbreak?
An outbreak typically begins with prodromal symptoms, such as pain, burning, or tingling along the distribution of a sensory nerve, commonly the genitofemoral nerve, which may precede the visible eruption by about 2 days. This pain can be particularly severe in the anal area if that's the site of infection. The eruption itself starts as a cluster of tiny vesicles, small fluid-filled blisters, which rapidly break open and erode to form shallow, open sores or ulcers. These ulcers are characteristically painful, figure 85.278.
Painful ulcers are a key feature. What is the first attack typically like? Is it worse?
Yes, the first episode, or primary infection, usually occurs around 4 days after exposure and is often the most severe. It's typically accompanied by systemic symptoms like fever, headache, myalgia, muscle aches, and often noticeable tender inguinal lymphadenopathy, swollen glands in the groin. The ulcers can be numerous and take 2-3 weeks to heal.
Are there specific ways it presents in women?
Yes, in female patients, the ulcers often occur on the labia, perineum, or buttocks, and can sometimes spread onto the thighs. Urethral involvement can also occur, potentially causing severe dysuria or even urinary retention, which may persist for up to 14 days if there's associated sacral radiculitis, nerve root inflammation, affecting the S2 and S3 spinal nerve roots. Vaginal or cervical lesions can also occur.
How is genital herpes diagnosed? Is it just by looking?
Diagnosis is often made clinically based on the characteristic appearance of the lesions. If there's clinical doubt, or for confirmation, viral detection can be achieved by either cell culture or polymerase chain reaction, PCR-based techniques, on a swab taken from the base of an ulcer. PCR is generally more sensitive.
And how is a primary infection treated? Does treatment help with recurrences?
The source states that all primary genital herpes infections should be treated with oral antiviral agents. Common medications include acyclovir, valacyclovir, or famciclovir, typically given for 7-10 days. Example dosages provided are acyclovir 400 milligrams 3 times a day, valacyclovir 1 gram orally twice a day, or famciclovir 250 milligrams 3 times a day. Antivirals shorten the duration and severity of the primary episode. For frequent or severe recurrences, suppressive antiviral therapy, taking medication daily, can reduce the frequency of outbreaks.
Are there risks associated with pregnancy?
Yes, a child born to a mother with an active genital herpes infection, particularly if lesions are present around the time of delivery, especially with the primary infection, is susceptible to a potentially fatal generalized herpes infection in the neonatal period. Cesarean section should be strongly considered in these circumstances to avoid transmitting the virus during passage through the birth canal.
A serious risk to the newborn. Is there any long-term health implication for women with genital herpes, like cancer risk?
Yes, the source mentions an increased risk of carcinoma of the cervix associated with genital herpes infection, though the primary driver of cervical cancer is HPV. It recommends annual cervical cytology screening, like a pap smear, for life for affected women.
That covers genital herpes. Syphilis is another cause of genital ulcers mentioned. What are syphilitic ulcers like? Are they painful?
Syphilitic ulcers, known as chancres, are typically the primary manifestation of syphilis infection, caused by the spirochete bacterium Treponema pallidum. A key characteristic is that they are usually painless. They are described as rubbery and indurated, meaning they feel firm or hardened at the base, often with a clean base and raised edges.
Painless, firm ulcers, a contrast to the painful ulcers of herpes and chancroid. How is syphilis diagnosed?
Diagnosis was traditionally made by identifying the motile spirochete, using dark field microscopy of fluid from the chancre. However, this requires specialized equipment and expertise. Modern serological techniques, blood tests that detect antibodies to Treponema pallidum, like VDR-LRPR, and specific treponemal tests like TP-PAPTA-ABS, are now considered more appropriate and are widely available for diagnosis.
The source notes the incidence of syphilis has been increasing. Why might that be?
Yes, there has been an increasing incidence of syphilis in many parts of the world since the mid-1990s, often linked to changes in sexual behavior, sometimes associated with the advent of effective retroviral drugs used to treat HIV, which may have led to reduced condom use in some populations.
And treatment for syphilis, is it still penicillin?
Yes, treatment is with long-acting penicillin, typically administered as an intramuscular injection. The exact regimen depends on the stage of syphilis.
Syphilis, painless, firm ulcer, diagnosed by blood tests, treated with penicillin. Now let's look at some tropical sexually transmitted infections mentioned that cause ulcers, starting with lymphogranuloma venereum or LGV.
LGV is an STI caused by specific, more invasive serotypes of chlamydia trachomatis, types L1, L3. It is primarily an infection of the lymphatic system and lymph nodes. It can affect both sexes. While traditionally considered rare in resource-rich countries, the source notes some recent outbreaks have occurred in Europe and North America, often seen in conjunction with HIV infection, particularly among men who have sex with men presenting with proctitis.
How does LGV typically progress? Does it start with an ulcer?
It starts with a primary lesion that develops 1 to 4 weeks after infection. This is usually a fleeting, painless, genital papular ulcer, which is often small and may go unnoticed. The more characteristic stage involves the lymphatics. Around 2 to 6 weeks after the primary lesion, the regional lymph nodes, typically the inguinal glands of the groin, become enlarged, tender, and painful, buboes. These masses of nodes can mat together above and below the inguinal ligament, forming a characteristic sign of the groove. The overlying skin may become reddened, the masses may feel fluctuant, indicating liquefaction or pus, and they can occasionally rupture and drain spontaneously, forming chronic sinuses.
So, a mild initial lesion followed by dramatic lymph node involvement, buboes. Are there other ways LGV can affect the body? Rectal involvement.
Yes, if the initial infection is in the anal area, common in those engaging in receptive anal intercourse, severe hemorrhagic proctitis, inflammation of the rectum, can occur, which, if left untreated, can lead to scarring, fibrosis, and potentially a rectal stricture. Chronic lymphatic obstruction caused by the infection can also lead to persistent lymphedema, swelling due to impaired lymphatic drainage in the genitals, elephantiasis, perineum, and occasionally the lower limbs. Urethritis and urethral stricture can also occur in men with LGV.
How is LGV diagnosed? Is it easy to confuse with other conditions?
Diagnosis is confirmed clinically based on the presentation, especially the characteristic buboes or proctitis, and by detecting antibodies to chlamydia trachomatis, though these don't distinguish LGV from other chlamydial infections. Specific diagnosis relies on detecting LGV-specific serotypes using NATE on samples from the ulcer, buboaspirate, or rectal swab.
And treatment.
Treatment involves a longer course of antibiotics than for uncomplicated chlamydia, typically doxycycline for 21 days. Alternatives include erythromycin or azithromycin. The source adds a specific note about managing the swollen lymph node masses, buboes. The multilocular lymphatic masses should not be incised like a simple abscess, although aspiration with a needle is permissible to reduce discomfort and prevent rupture.
Lymphogranuloma venereum, mild initial ulcer, severe lymphatic disease, requires specific testing and longer treatment. Next, lymphogranuloma inguinale. Different name, different disease.
Yes, although the names are confusingly similar, it's a distinct condition. Also known as donovanosis or granuloma inguinale, it is a chronic and slowly progressive ulcerative tropical disease that primarily affects the genitals and surrounding tissue, but occasionally occurring elsewhere, like the mouth. It is usually sexually transmitted, but less contagious than other STIs.
What causes it and who is typically affected? Is it common outside the tropics?
It is caused by the bacterium Klebsiella granulomatis, formerly Halomatobacterium granulomatis. The source notes it is most commonly seen among socially deprived populations in specific tropical and subtropical regions. For example, Papua New Guinea, parts of India, Africa, South America. It's rare in developed countries, usually seen in travelers or immigrants from endemic areas.
What is the incubation period and how does the lesion develop?
The incubation period varies greatly, but typically between 7 and 30 days, possibly longer. It starts as a painless vesicle or an indurated, hardened papule, usually on the external genitals but occasionally elsewhere. This initial lesion gradually erodes into a slowly extending ulcer. This ulcer has a characteristic beefy red, highly vascular, granulomatous base, tissue that looks granular and swollen and bleeds easily. More chronic lesions may become grayish, especially at the edges, and can become hypertrophic or fibrotic.
Is the ulcer painful?
The ulcerated area may bleed easily if touched, but according to the source, it is usually surprisingly painless, which can lead to delays in seeking treatment.
What happens if lymphogranuloma inguinale is left untreated?
Without treatment, the ulceration slowly spreads and destroys tissue. Healing is only partial, and extensive scarring, including keloid formation, is common. Lymphedema can also occur. Importantly, malignant change, squamous cell carcinoma, may develop in the chronic lesions after months or years.
How is lymphogranuloma inguinale diagnosed?
Diagnosis is made by microscopy of crushed tissue smears or biopsy material taken from the edge of the ulcer. Microscopic examination, using GIMSA or Wright's stain, shows the presence of characteristic short, gram-negative rods with bipolar staining, dominant bodies, within the cytoplasm of large mononuclear cells, macrophages. Culture is difficult.
Seeing those Donovan bodies inside cells is key, and treatment.
Treatment is with antibiotics, often requiring prolonged courses, weeks to months, until the lesions have completely healed. The primary recommended treatment is azithromycin. Alternatives include doxycycline, ciprofloxacin, erythromycin, or trimethoprim sulfamethoxazole.
That covers lymphogranuloma inguinale. The final genital ulcer ST I mentioned is chancroid. How does this differ?
Chancroid is a sexually transmitted acute ulcerative disease caused by the bacterium Haemophilus ducreyi, which is a gram-negative facultative anaerobe. It's more common in certain tropical and developing countries, but outbreaks can occur elsewhere.
What is the incubation period and typical presentation of chancroid? Is it painful?
Following a shorter incubation period, typically 3 to 10 days, one or more soft, painful genital ulcers appear. Figure 85.27b. In contrast to the painless ulcers of syphilis and lymphogranuloma inguinale, pain is a key feature of chancroid ulcers. They often have ragged, undermined edges and a grayish or yellowish base. The development of tender, painful inguinal lymphadenopathy, buboes, commonly follows the appearance of the ulcer in about half of cases. These buboes can become fluctuant and rupture.
So painful ulcer plus painful swollen nodes is characteristic. How is chancroid diagnosed?
Diagnosis can be difficult. Gram stain of ulcer exudate may show characteristic school of fish arrangement of the bacteria, but it's often insensitive. Bacterial culture of material from the ulcer base or bubo aspirate is the definitive method, but requires special media and is not always available or successful. PCR techniques to detect the DNA of Haemophilus ducreyi are becoming more common and are more sensitive. Diagnosis is often made clinically based on the typical presentation, especially in relevant geographic settings, after excluding other causes like syphilis and herpes.
And treatment.
Antibiotic treatment is usually effective. Recommended single-dose regimens include ceftriaxone, intramuscular, or azithromycin, oral. Multi-dose regimens include erythromycin or ciprofloxacin. Treatment usually leads to rapid improvement of ulcers and buboes.
That provides a detailed look at the various causes of genital ulcers, each with their own distinctive characteristics and diagnostic approaches. Herpes, painful vesicles ulcers, recurrent. Syphilis, painless firm chancre. LGV, painless fleeting ulcer followed by painful buboes. Lymphogranuloma inguinale, painless chronic beefy red granulomatous ulcer. And chancroid, soft, painful ulcer, often with painful buboes. Knowing these differences is clearly vital for diagnosis.
It absolutely is. Distinguishing them clinically is the first step towards appropriate investigation and treatment, and managing potential complications and transmission.
Finally, in this section on infections, condylomata acuminata, more commonly known as genital warts. How common are these?
Genital warts are a very common sexually transmitted infection caused by infection with the human papillomavirus, HPV. While HPV infection itself is extremely widespread, only a relatively small proportion of infected individuals actually develop visible warts. Many infections are cleared by the immune system or remain subclinical.
What specific HPV types cause genital warts? Are they the same ones that cause cancer?
Genital warts are most commonly caused by low-risk HPV types, specifically types 6 and 11. Crucially, the source states that these specific HPV types do not cause cervical cancer or other HPV-related cancers like anal or oropharyngeal cancer. This distinguishes them from the high-risk HPV types, like 16, 18, 31, 33, etc., that are associated with malignancy, although co-infection with high-risk types is possible.
That's an important distinction regarding cancer risk. Are genital warts different from ordinary skin warts you might get on your hands?
Yes, although ordinary skin warts caused by other HPV types can occur on the genitals through direct contact, they are generally different in appearance from typical genital warts, condylomata acuminata. Genital warts are typically softer, sometimes flesh-colored or pinkish, often occur in clusters, and can be flat, papular, raised, cauliflower-like or peplomatous, or sometimes pedunculated on a stalk. Figure 85.27c shows typical appearances. Common skin warts tend to be harder and more keratinized.
Where do genital warts typically occur on the genitals?
They have a predilection for moist areas. In men, they most commonly appear under the prepuce, particularly in the coronal sulcus behind the glands, on the frenulum, or around the urethral meatus. However, they can be found elsewhere on the shaft or scrotum. In women, they are most commonly found on the vulva, labia, clitoris, perineum, and perianal area, but may also occur inside the vagina and on the cervix. Perianal warts are common in both sexes, especially those engaging in anal intercourse. Warts can also occur inside the urinary meatus.
Should other STIs be screened for if someone presents with genital warts?
Yes, the force advises that other associated STIs should be excluded in patients presenting with genital warts, as people are often exposed to multiple infections. In women, this includes conditions like candidiasis and trichomonas infection. In men, testing for syphilis or gonorrhea might be appropriate depending on history. Testing for HIV is also often recommended. Genital warts may also be more extensive, persistent, or difficult to treat in patients with underlying immunodeficiency, such as HIV infection.
And what are the treatment options for genital warts? Can they be cured?
Treatment aims to remove the visible warts, but it doesn't eradicate the underlying HPV infection, so recurrence is common. Treatment can be achieved by chemical or physical means. Patient-applied topical chemical treatments include agents like podophyllitoxin solution cream or imiquimod cream, which stimulates the local immune response. Provider-applied treatments include cryotherapy, freezing with liquid nitrogen, application of trichloroacetic acid, TCA, or surgical methods.
What are the surgical or physical methods?
If chemical methods fail, are unsuitable, or for larger or more numerous warts, physical removal methods are used. These include surgical excision, cutting them off, electrocautery, burning them off, or laser ablation, using CO2 or other lasers. The source notes that circumcision is sometimes advised for men with extensive or recurrent warts located under the foreskin, as removal of the foreskin removes the affected area and changes the local environment, which can help prevent recurrence.
So, topical treatments or various physical methods for removal, but recurrence is possible because the virus isn't eliminated. That concludes our extensive look at infections and inflammation affecting these structures.
It's certainly a wide range, isn't it? From life-threatening emergencies like Fournier's gangrene to very common STIs like urethritis, herpes, and genital warts, each with its own causative agents, presentations, and management principles outlined in the source.
Well, we have indeed covered an immense amount of ground in this deep dive, drawing exclusively from the provided source material, Bailey and Love. We started with the fundamental anatomy of the male and female urethra and the penis, segment by segment, function by function. We then explored the fascinating yet sometimes challenging world of congenital anomalies, like the obstructive posterior urethral valves and the varying presentations of hypospadias requiring precise surgical planning.
We moved on to the impact of physical trauma, detailing injuries from falling astride causing bulbar ruptures to those severe disruptions associated with major pelvic fractures, understanding their distinct clinical signs and the principles of often delayed surgical repair. We delved deep into the chronic problem of urethral strictures, learning their diverse causes, infection, trauma, LS, iatrogenic, how they narrow the channel, the diagnostic methods like urethrography, and the evolution of treatment from ancient dilatation to modern specialized urethroplasty techniques using grafts like buccal mucosa.
And we touched on other conditions like urethral fistulae, stones, and rare tumors before shifting our focus to the female urethra, noting its shorter length, full-length sphincter activity, and distinct conditions like caruncles and diverticula, while also seeing parallels in managing strictures and malignancy.
We then examine diseases of the foreskin, clarifying physiological versus true phimosis, discussing the indications and public health aspects of circumcision, recognizing emergencies like paraphimosis where the foreskin gets stuck, and managing common inflammation like balneoposteitis.
We also explored direct injuries to the penile structure itself, from traumatic skin avulsion requiring complex repair to the dramatic event of penile fracture needing urgent surgical intervention, and the danger of strangulation from constricting rings. We spent significant time on conditions affecting penile function and form, detailing the common, often vascular, causes, assessment, and escalating treatments for erectile dysfunction, understanding the pathology, active versus stable phases, and surgical management of Peyronie's disease and congenital curvature, and recognizing the critical time-sensitive nature of priapism as a surgical emergency, carefully distinguishing its painful ischemic type from the painless non-ischemic type.
And finally, we immersed ourselves in the broad category of infections and inflammation, from the urgent, life-threatening Fournier's gangrene to the common causes of urethral discharge, nonspecific urethritis, often chlamydia, and gonorrhea, noting issues like asymptomatic infection and antibiotic resistance, and other conditions like Reiter's reactive arthritis and periurethral abscesses. We finish with a detailed look at STIs presenting as genital ulcers, herpes, syphilis, LGV, lymphogranuloma inguinale, and chancroid, carefully differentiating their key features, and covering the very common genital warts caused by low-risk HPV.
By systematically unpacking the details presented in this source, you, the listener, have gained a level of insight into the clinical presentation, the diagnostic approaches utilized, and the principles of management and treatment for this wide array of conditions, much like a professional reviewing this material would need to know. You've seen the interconnectedness of anatomy, pathology, and clinical practice.
Absolutely. This deep dive, based solely on the Bailey and Love excerpts, has hopefully provided a structured, detailed understanding that goes far beyond a superficial overview, equipping you with knowledge points that stick and provide a foundation for mastering this information.
Right. And reflecting on the breadth of issues we've explored today, from microscopic organisms causing painful ulcers or potentially triggering autoimmune disease, to complex surgeries rerouting anatomy after devastating trauma or congenital defects, and the severe consequences that can arise from conditions affecting these seemingly simple tubes and structures, it really makes you appreciate just how critical their proper function is and how many different ways things can go wrong, doesn't it? It certainly underscores the importance of understanding this often under-discussed area of medicine.